If I could have your attention, please. Thank you. I'd like to welcome you to the Baker Institute for Public Policy. We're delighted you can attend today's conversation on improving health outcomes and well-being in Texas. And I want to thank all of our partners in the Texas Consortium for Non-Medical Drivers of Health, and to all of you who work on behalf of healthier, more resilient communities. At the Baker Institute, our mission is to bring scholarship and rigorously fact-based, nonpartisan research together to address the most pressing challenges facing the state, the nation, and the world. For more than 30 years, we have convened experts, practitioners, leaders across sectors to advance sound, evidence-based solutions. We don't just admire problems. We propose ways of dealing with them and, if possible, resolving them. Today's program reflects that mission, that commitment, bringing together leaders who are driving innovative, evidence-informed approaches to some of the state's, and I dare say the nation's, most urgent health challenges. Now, the Center for Health Policy here at the Baker Institute is central to this work to strengthen health outcomes and inform effective policy in Texas. We are pleased to welcome our new director, Dr. Heidi Russell. Heidi, where are you? I assure you, Heidi is here. And Heidi Russell, who joins us from Texas Children's and the UT system. Dr. Russell is a national leader in child health, and she's already reshaping this pillar of our health policy portfolio, bringing a sharp focus to the systems and supports that influence the lives of children and families. Her leadership strengthens the center's efforts to advance policies that improve outcomes, access, quality across Texas. Now, today's conference event, hosted by the Texas Consortium for the Non-Medical Drivers of Health, reflects our commitment to advancing policy, research, and practices that recognize what we all know to be true. Health goes beyond health care. Health is shaped by the conditions in which we live, learn, work, and play, and our policies must reflect these realities. And that is why the Baker Institute has strengthened its focus, our focus, on non-medical drivers of health, because improving outcomes requires cross-sector collaboration, updated care models, and attention to the challenges families face beyond the clinic. I'm grateful to each of you for joining us today as we work together to improve health in Texas. Thank you all. And over to you.
Thank you all for being here and joining us again this year. It's been a busy year for all of us. This year's conference looks a little bit different than last year. We just thought it was really timely with all the major changes at the federal level, and then coming out of a session, a state session, that we have a little bit more policy-focused agenda this year. We have a strong agenda set up for you. We'll start out with our keynote address, followed by a conversation with a staffer from the Senate, Texas Senate, and then we have a panel of advocacy experts to talk about what they saw during the session. Following lunch, please stick around. We're going to have small group discussions at your table to kind of talk about what you see in your work as policy opportunities for us to be focusing on in the next year. A couple housekeeping issues to be aware of. First of all, on your table, there's a couple different kinds of documents. The green one shows the agenda and our list of speakers and the facilitators that are going to help us with our small group discussions. And the purple one has some instructions for what the small group discussions are going to be about and how that works. Also on your table are some note cards and pencils. That's how we're going to do the Q&A. So as questions arise, write them down, and when we get to the Q&A session for each of the presentations, just raise your card up, and we've got some students who will run around and kind of grab them and bring them up to the front to get your answers. For restrooms, the ladies' room is right over here on your left, and the men's room is over here on your right. This event's possible because of the Baker Institute staff who worked really hard to manage all the logistical details to make this a comfortable meeting for us all. I also want to acknowledge the financial sponsorship of the Texas Association of Community Health Plans. The Texas Association is a membership organization supporting the health plans covering over 2 million Texans. This is the second year in a row that Janet Walker and her team has supported us in making this conference possible. I also want to acknowledge the Episcopal Health Foundation for its financial support of the Texas Consortium, which makes all our analyses and writing and commitment to health policy in Texas to advance. So why non-medical drivers of health? One thing that we really try and continue to emphasize is that health is more than just healthcare. And we know the conditions that people live in really are the major drivers behind, the quality of the health they have. So if we don't address these other non-medical needs, the healthcare that people do have access to is just not going to be as effective. So when we see the headline news, a lot of the health news that we see is about costs and the escalating prices of healthcare itself. But really, to get at this issue of value and how do we get more bang for our buck, the other part of that equation really is like, what is the quality of health that we can achieve by the different interventions that we have available to us? And if we just compare ourselves to other high-income nations, you can see we're just completely an outlier in terms of the amount of dollars that we spend relative to the performance that we're getting out of our system. So, detecting non-medical needs and addressing those is one way for us to start bending that curve on quality. And our state legislators recognize this. This is a brief clip from Senator Colcourse, who chairs the health committee. I'm just going to play this.
Tell you this, that
can you turn it up?
We said this when I laid out Senate Bill 25. We spend more money as a nation than any other nation in the world. Our life expectancy is last in the G7 nations. It is 60th as compared to other nations. We're talking about third world nations. Obviously, we're doing something wrong, that we need to reverse trend. And I will.
So there's a lot of recognition and a growing recognition that it's not just the price that's the issue. It's just that we're not getting the outcomes that we really want to achieve, and that's where non-medical drivers come in. This has been a really dynamic year for many of us in the audience, where the federal landscape has been changing really rapidly, and lots of times it doesn't always come with a lot of explanation. So it's been tough for many of us to kind of be strategic in our planning and navigating kind of the new the policies going on both at the state and federal level. That's why we've kind of designed this agenda today to kind of reveal a little bit more about what we see as opportunities moving forward in non-medical space. That's why we're doubling down on our policy work. We're, as a consortium, we're built to help translate world insight into policy action. And this year, that matters more than ever. We have a responsibility to advocate, to educate, and ensure the financing structure supporting non-medical drivers remains strong, evidence-based, and aligned with the needs of Texas communities. As you engage in today's presentations, I challenge you to think both practically and ambitiously. Think about what we can accomplish now and what we must build towards to ensure that non-medical driver programs thrive in the years ahead. Your insights today shape our policy priorities and the strategies we'll carry into the year ahead. Next, I will turn it over to my colleague, Elena Marks, who had the vision to found this consortium and who continues to provide strategic guidance and connections that carry us forward. Her leadership has been essential to our success. Elena.
Great to see you all here and in our own home. We've hosted the conference over at the BRC the last few years, but this is where we actually live and work. It is my pleasure to introduce our keynote speaker today. Dr. Mark McClellan probably needs no introduction. He's a native Texan. He's a physician and an economist. He is the director of the Duke Margolis Institute for Health Policy at Duke University. And he used to run both the FDA and CMS, and boy, do I really miss him now. But I got to know Mark in the aftermath of Katrina. All of you Houstonians know we took in 250,000 people from New Orleans and the surrounding area, and we had to provide health care to them, and we did a really good job on a shoestring budget. And we were very fortunate to be able to partner with Secretary Mike Leavitt at the time and with Mark, who was running CMS at the time. And the support of the federal government was essential to us, knowing that they had our backs. And I have stayed in touch with Dr. McClellan over the years and followed his career and watched the really interesting things he's done, and I'm really delighted to welcome him up to give a keynote and give us sort of a federal and broader perspective about what's going on in the health policy space in general and regarding non-medical drivers of health in particular. So give him a warm welcome.
Elena, thanks very much, and it is such a pleasure to be here with all of you this morning. The obvious reason I'm glad to be here is because the work you all are doing as part of the Texas Non-Medical Drivers of Health Consortium is really important and timely today, and Charles made that clear from his introduction. It's also great to be here because of that long relationship with Elena. There's nothing like dealing with a public health crisis that builds a team spirit and shows people when we work together what we can accomplish. But the other two reasons that I'm very glad to be here with this group are, first of all, is Elena mentioned, I am a North Carolinian right now, but Texan by birth and culture and family, a fourth generation Austinite. I still have a lot of family in the state. I have a mom who was passed away this past year, but was very involved in Texas politics, a grandfather who was involved in Texas law and rewriting the Constitution, and a family that said, above all in life, it's not the dollars you make, it's the difference you make. And that's a reason why I really enjoy working with the Baker Institute. Ambassador Satterfield, thanks for the introduction. I remember working with Ambassador Baker in the Bush administration and in my work from academics and other private sector jobs over my career. He and the approach that the Baker Institute has taken over the years has really made a difference in health policy and public policy more generally, and I think we need that now more than ever. I'm going to talk about some of the challenges that we're facing today and working together and getting things done, but also about the opportunities, and this is a very strong foundation here to build on. Which brings me to the last reason I'm very happy to be with you. I'm looking around the room, I've seen a lot of, how many of you are students who are here today? So great, thank you for coming out. I know you got other things to do with courses and probably finals and things like that coming up. As you look ahead to your career, there are going to be more opportunities than ever to take fresh approaches to dealing with problems, particularly in healthcare, because as you just saw on the introductory comments from the Texas Legislature this year, what we are doing now is not working, and change is hard. But the best way to make change is to participate in efforts like this and get outside of your disciplinary comfort zone, get outside of your comfort zone of being with people who think like you. And it's programs like what happens at the Baker Institute here that bring together different disciplines and encourage exchanges of ideas among people with different perspectives that I think is the key to progress. And we're seeing some of that happen right now. I'm going to talk about some of the challenges and some of the opportunities when it comes to addressing non-medical drivers of health and improving health in particular. But we have so much more work to do, and I know it's not easy, but I hope you will keep with it and keep being comfortable with getting outside of that comfort zone. Now, in my remarks, I'm going to talk about a range of topics today. First, I want to introduce the institute where I work now, the Duke Margolis Institute for Health Policy at Duke University. We do have some collaborations here in Texas. I'll talk about those. A lot of those are thanks to Elena and TAC and the Texas Association of Community Health Plans and the other organizations here that continue to come together to work on these hard problems. It's been a privilege to work with them over the years. Then I'll talk about some of the national challenges and opportunities that exist for making the kinds of reforms in healthcare that you all are focused on. The challenges are big, but that also means that the opportunities are big too. I'll try to highlight some of those. Talk a little bit about the Texas landscape, but you all have a lot of people you're going to hear from today who know a lot about that, so just want to put that in context. And then I want to talk about some of the lessons from North Carolina and from work that we're now doing with other states besides Texas and North Carolina in the same direction. There is a lot going on now around the country. You might say, well, you know, how relevant can North Carolina be to Texas? It's like they're actually more in common in those states than you might think. Texas has a staunchly Republican legislature, so does North Carolina, veto-proof Republican legislature. We have a Democratic governor right now, but it's pretty moderate. It's a very purple state that consistently has voted for President Trump. And we found some ways to work together on these healthcare issues to the point of some programs that have addressed non-medical drivers of health and, in fact, implemented Medicaid expansion based on the principle of paying for health and documenting all along the way that we are actually taking steps that to the legislative discussion that you just saw, bring down costs and improve health outcomes. That doesn't mean it's been easy. We're having some budget struggles right now, just like other states are around the country. We're looking at the implementation of the Big Beautiful Bill, which if you look at the state-by-state impact, we're up near the top. We are probably at the top. Texas is not far behind in terms of financial impact. But also, do you all know who which two states have the highest number of rural residents in their states? Who's number one? Texas is always number one. You all know that. Number one in terms of rural residents. Who's number two? It's actually North Carolina. It's a very diverse state. So just like Texas, we have some urban areas, some big academic institutions, commercial, financial, and Charlotte. But only 100 miles away are some very isolated areas with rural hospitals that have closed and serious access problems. You all may remember we talked about Katrina. Last year, Hurricane Helene dumped 4 feet of water in a day on our western North Carolina valleys around Asheville and other towns like that. Huge impact that was made a bit easier to deal with. It was not easy to deal with because of steps we had taken to address non-medical drivers of health, and I'll try to get back to those too. So some areas of common ground, and I hope we can keep working together to make progress on these challenging issues, and I'll talk some about that before wrapping up. So the Duke Margolis Institute has, I think, a lot in common with the Baker Institute. This was a university-wide program that I had the privilege of bringing together support and university backing to create. It is a health policy focused program, but it is not located in a public policy school or a medical school or a public health school or anything like that. We're physically located in 2 places, actually the business school at Duke, because there is not a solution to healthcare challenges in any country, I'd say around the world now, that isn't a public-private collaboration that relies on private innovation, private capital. It's very hard to find the amount of investment you need just from the public sector in any country in the world today. But also, besides the private side, needs government policy that's predictable, that can help make the kinds of investments and changes that are needed pay off. And we also have an office in Washington, D.C. About half of our research staff is built there. That's what's up at the top right of this slide. We really try in all of the work that we do bring together, on the one hand, ongoing engagement with stakeholders. That includes, federal and state officials. Their perspectives and insights are really important. but also advocacy groups, different stakeholder organizations. A lot of those have their national offices based in DC. A lot of the people that work with us are people that might otherwise be on Capitol Hill or working at CMS or FDA or something like that. And it really helps to bring in perspectives about not only what's feasible, what can and can't be done politically, but what's feasible from the standpoint of technical insights. And we pair that up with our work with our research collaborators, our academic faculty from across Duke University. So we have affiliated faculty in business, law, medicine, engineering, statistics, all of whom have relevant insights for making healthcare better, and all of whom, at least the ones who are working with us, they need to publish in the academic journals, they're researchers, but they want to make sure their work is relevant. And it's very hard to have academic studies that just get published in journals in one particular discipline. They're going to translate to real impacts on practical policies unless you approach this work as a team with a lot of attention to understanding stakeholder perspectives, what's out there that actually seems to be working, bringing in that data to help guide your research, and then conversely, making sure you're focusing on the right practical problems and listening. I've written a lot of academic papers in my life. No one of them ever had an impact on policy by itself. It was always like putting it together. So that's what we've tried to build into academics at Duke. You might think, how do you get sustainable funding, and how do you bring everybody together? Universities can be kind of centripetal places and so forth, but there are ways to solve all of that, and I hope we can see more of it happening in healthcare and these other big global issues that we're facing. As part of this work, we've been around for about 10 years now, and developed some state collaborative approaches that bring together groups sort of like the non-medical driver of health consortium has been doing here, to work actively on developing that evidence and making sure it's practically relevant and applicable in the state. So in North Carolina, we started with a CMS grant under the first Trump administration to facilitate state transformation. That's transitioned to a program that is self-sustaining with a combination of philanthropic support and support from the state. It's a true public-private collaboration, and we're working on a range of issues now that I'll talk about in a little bit more detail going forward. There are other states that are implementing the same kind of approach now. We're not going to do it, it needs to be very locally based, a place like Baker Institute. We also collaborate a lot with some of the staff and researchers at UT Dell in Austin that are working closely and have a lot of legislative direct experience too. But this kind of approach is being tried in other states, and it's the kind of thing that we can support, but that obviously needs to be led locally. And if you think about, or at least one way that we found useful to think about where we are and where we need to be, which is sustainable health care, and as the senator was saying, that's less expensive and that demonstrably does more to improve health. Getting from here to there is hard, especially when there are different views out there among different stakeholders, not only about what's important, and we've got a lot of consensus today that these non-medical factors, lifestyle, behavioral pressures, nutrition, et cetera, matter a lot, but what exactly are the policy steps that are feasible and effective to implement to get there? We've tried to adopt this kind of approach, identifying some clear reform goals. That's happening in Texas around issues like food as medicine, and as we've seen over the last couple of years, around some areas in maternal health or other behavioral health that can be addressed through innovative approaches, and then getting to a critical mass of common ground. Now, everybody maybe starts with thinking that these issues are really important. Then when you roll up sleeves, it gets tougher. Well, these reforms cost money. They require some changes in the way that we're paying for services, the way that we're regulating services, that can be disruptive. But starting to build that critical mass of support, the only way you do it is by building trust. The only way you build trust is by having a combination of honest engagement, earnest engagement, spending time coming up with a logic, plausible model, a sensible, empirical approach, and then making sure you're empathizing with the people that you're working with, making sure you're seeing this problem from their standpoint, which again, these days can be quite different than yours. And none of this is easy, but it's definitely doable. The other thing that's critical for these reforms is so-called value-based payment. This is it's a term that people use a lot. I would really highlight that what it means, I think most importantly, is the way we say it in North Carolina is we're moving from paying for medical services to paying for health. Technically, that means payments are more at the person level or at the set of an overall set of services where the payment amount is at least partly tied to how much of a difference this set of services brought together around a person or a family is making for their well-being, not just tied to how many specific office visits they had or how many specific meals they were provided or things like that. It's moving towards a person focus in payment, which facilitates paying for a lot of stuff on a more targeted basis, a more integrated and coordinated basis than you get with a fee-for-service payment system with tens of thousands of services, and it does not get more coordinated or more integrated by adding on still more services. If you can get to those steps, there are a lot of opportunities, and I'll talk about them in the remainder of my remarks, to get aligned policies that people will agree on. So everybody wants data interoperability. How do we make that happen? We got to start with the areas where there's a motivation to not just follow the standards, but adopt it in your data systems. Everybody wants to move to value-based payment. If every single health plan and Medicare and Medicaid and commercial plans do it in a completely different way, it's going to be awfully hard to make progress. Everybody wants to get better evidence on outcomes. If we do that in a fragmented way, it's hard to make progress, but there are ways. If you have this collaborative approach, it's got to be state and locally driven, there are ways to make it happen, and that's the pathway to sustainable care. So easy, right? I would say that this is probably the most opportune time that I can remember from a technology standpoint for driving these reforms. So just came from North Carolina yesterday and Washington before that, where CMS announced a major initiative, look it up, called the Access pilot program, which is now going to be making direct payments for digital and AI tools that can be used by Medicare beneficiaries to get better outcomes for chronic diseases and for the risk factors that influence those diseases. If you look at what's going on in technology today, there is so much happening. If you look at its connection to the actual delivery of healthcare, we are still in the early days. I mean, most of the early tech and AI applications that we've seen in healthcare so far are kind of related to our, they're making things more convenient. They're certainly helping with doctors' time dictating notes and things like that. But a lot of the early applications are really more about trying to make fee-for-service work a little better. You know, you can get more billing codes documented if you got AI pulling it out of the charts. That increases reimbursement. You don't have to spend as much time filling out the paperwork for the health plans. On the plan side, a lot of investment in prior auth AI tools. There's kind of a prior auth arms race going on now. All that's kind of within the fee-for-service context. That is not going to deliver the kind of transformative value that could be possible through digital and AI tools. So in this program that CMS just announced, the payments, back to my point, there's going to be a payment per month for these tools. That payment is going to depend a lot on whether the tools actually lead to lower rates of progression of chronic diseases, better diabetes control, better blood pressure control, slowed progression of kidney disease, better functional status for people with behavioral health problems or musculoskeletal problems. ambitious to do, but very much in the direction of paying for health. Also on this list, personalized risk assessment. So the other thing that technology makes possible and better data makes possible is identifying who's at risk and for what, and potentially what particular interventions would matter the most for them. But there's a difference between being able to, know that a train wreck is about to happen, or a meteor is about to hit the Earth. I guess it's better for predicting hurricanes. But what really matters is when you can identify so-called rising risk patients and rising risks in families and other settings, and intervene before it happens. It's the impact on risk that matters. That's what really matters for healthcare reform, and I'll talk about some examples of how to bring that together there, how to bring that kind of data together, and how much of a difference it can make. Convenient, accountable healthcare support, stronger primary care, well-integrated specialty care. This is a vision. The good news is that there are plenty of examples around the country, and I would say around the state of Texas, of doing this well, at least better than traditional healthcare. They have not scaled. And I think the question we have to ask is, why have they not scaled? What is the combination of the policy steps, the private sector, and local innovation that can make that happen more easily? Everybody probably saw, I don't know why they buried this over Thanksgiving week, but the GLP-1 negotiations that the president announced, much lower prices for GLP-1 drugs. There are so many transformative therapies out there. We haven't figured out how to make them effectively available at a sustainable price that also creates sufficient incentives for further innovation. But I have to say, on the Trump approach, basically I think kind of amounts to, well, let's get the price down significantly, and in conjunction with that, look for the other shoe to drop next month. We're going to have broader coverage for these treatments, so lower price but higher quantity than would have happened under our traditional approach for paying for innovative drugs, which is bring the drug to the market, the highest price that the market may bear, because if you're a manufacturer, you know that when you get to market, we don't have a delivery system set up to adopt and incorporate these new drugs into treatment very effectively, especially those that can have an impact on primary care and chronic disease management. And B, you're going to face prior auth and out-of-pocket payments and other restrictions on use anyway. If you look at the market impact of new drugs, it's 9 or 10 years after a drug comes to market when it gets maximum revenues. And over that time, the price comes down, the volume goes up. I think the reform that the president and their negotiating team may be backing into, I give them some credit for the strategy here, but it's basically, let's move that forward. Let's have the lower price earlier, the higher quantity earlier, and have a win-win situation with a more prevention-oriented healthcare system. We're going to have to solve all of these problems to get to more sustainable healthcare. And there are a lot of initiatives going on now, and I'll talk about them briefly at the federal level and in some states that could be adopted by other states that are helping with that. But key to all of this is moving from volume to value and focusing on outcomes. You might say, well, that sounds nice, but let's deal with reality. For any of you who are working in the safety net programs, and thank you for your committed and really critical service, it is getting harder than ever. So this is, over the years, healthcare costs have kind of gone up, but so has things like Medicaid enrollment. But we're seeing a disconnect now that is pretty concerning, right? With healthcare costs, if you look at the latest projections from the Kaiser Family Foundations, 7-9% growth, that's significantly faster than inflation. No signs that that's going to ease up. Look at the drivers, demographic shifts, workforce challenges in healthcare, consolidation in healthcare, higher prices, and just real problems in access resulting. When you look at what Americans are most concerned about today, it's not only that their prices for what they're paying for healthcare has gone up. Many places you cannot get an appointment with a primary care physician for 3 or 6 months. So there is no easy solution to that on the horizon right now. It's going to take some work to change that. So it makes it awfully hard to think about how to make progress on the issues that I just described when it's so hard just to try to continue to sustain the programs that you have in place now that may not be perfect but are providing critical access and needed support for people. So the challenges here are urgent costs and access problems right now. So in North Carolina, our state budget is at an impasse because we've got like Republicans who should be able to agree on this. They don't know how to get to a balanced budget yet. They disagree on that. And so some of our innovative programs are kind of stuck or going slow while we work through all of that. Makes it hard to do innovation with this kind of financial pressure in place. There is uncertainty about which of these reforms work. All that stuff that I've been talking about, that sounds good when I say it, but believe me, it is not easy to implement and scale in practice. So how can we learn better and faster at a time when we're facing these budget pressures? And there's that big beautiful bill. So the OBBBA, it was passed, had some important implications for social programs. I'll talk a little bit more about those in a minute, but for Medicaid eligibility and for so-called state-directed payments, Texas and North Carolina also have in common. They depend a lot on those. And so while there are a lot of struggles right now that state legislatures are trying to work through to continue current programs and try to do things that are innovative, there's more coming. So the big effects of the OBBBA are not really going to be felt until like next year, and especially in 2027. So I just want to be clear, this is not going to be an easy environment for driving change. But there are a lot of federal supports out there, and I think we're kind of at a point where the question is, in every silver lining of every challenge is an opportunity. What is hopefully very clear from what I've said, and very clear, I'll see how the rest of your discussions go today, is that what we're doing now is not sustainable. It is not going to continue to work. You're going to continue to see pressure on prices for providers, pressure on access to providers as they pull out of current systems, and challenges in affording new technologies, innovative approaches if we just do it in our traditional fee-for-service fragmented way. What are some opportunities to moving forward with this? Well, I have to say it's, Trump administration has been Trump version 2. It's been an interesting experience, but I do want to call out the team at CMS. My successor there, Mehmet Oz, never thought I'd be saying that, but actually had a chance to talk with him right after the election. He was one of the early nominees from President Trump version 2. And it wasn't just me. He talked to a lot of people. It was a good trait if you're going in to lead a new agency, is realize how little you know and how hard it's going to be. So talk to people. They want to help. They want you to succeed because agencies like CMS are so important. So it wasn't just me, but lots of people. But he got advice pretty consistently that, number one, hire a team around you of political appointees immediately and make sure they are experienced in the agency that you're dealing with, either from being in government experience or from having experience in the private sector, in healthcare, working with the agency. And number two, work with the career staff because they know so much. And whatever agency you're in, the people who are in the federal government are there because they care about making a difference in people's lives, and they just want an opportunity to carry that out. It can work under, I've seen this happen in a I've worked for President Clinton as a political appointee, President George W. Bush. You can work with career staff no matter what party you're in, as long as you're following thoughtful evidence-based approaches, experienced approaches like you can get by building a team like I just described. So he did that. And so when other agencies, January 21st, DOGE came along, which shouldn't have been a surprise for everybody, but President Trump had been saying since the campaign, I've learned a lot since 2017, and so had his budget director, Russell Vogt. Many agencies did not have political leadership in place, because you don't get confirmed for another couple of months. They had DOGE disruptions that were basically externally imposed, and it's been pretty disruptive since. So the DOGE disruptions are, those are kind of over, but they're still, this approach of let's go bold and let's go fast. That's a persistent. That is a feature, not a bug, of the Trump version 2. In contrast, at CMS, there is a political leadership staff in place. There's a career staff in place, including a chief operating officer who started working for me came in under Part D to help us prevent fraud, worked her way up to being COO of the agency by the time President Obama was in. Retired from that, was working in the private sector and still making a difference in policy. I helped talk her into going back in. I remember she called me then on January 21st. It's like, Mark, what the hell did you get me into? But she's worked through it. And what the agency did, they still got DOGE. They still had significant reductions in budget, but they had a team there that knew where, look, there are opportunities to make our agencies work more efficiently. And sometimes, a big, bold push, if done right, I'm not saying this is the right way to do it. If you're going to do a RIF or if you're going to do a reorganization, it's best to take, a few months, think about it, and then, execute effectively. So this was not quite that, but they ended up reducing a lot of duplicate. They preserved staff. They ended up reducing a lot of contracts. It turned out that every single Medicare and Medicaid pilot program in the Innovation Center had a separate data contract and a separate analysis contract, which really got in the way of, my point about more integrated data and supports and things like that. So, not easy, but it has enabled, if you look at what CMS is doing as an agency, you may not agree with everything they're doing, but they are hitting on all cylinders in terms of the trains running on time. Every single regulation is out on schedule, and they're undertaking some major initiatives. I talked about drug pricing. I talked about the announcement yesterday on, building a better digital technology ecosystem that's paying based on value. They're getting a lot done, and that's not by accident. You can trace it back to these management approaches and the kinds of approaches I've been talking about so far today. So in terms of health technology and prevention initiatives, a lot to build on at the federal level. That digital innovation program that I just announced, I just talked about being announced yesterday. I don't announce stuff from CMS anymore, just try to help them do the right thing. That was directed at Medicare, but if you read the accompanying announcement, it said, hey, Medicaid programs, if you want to do this, you do not have to implement a waiver. You can adopt these same kinds of technology payments in your Medicaid program, do it through a so-called in lieu of service modification to your Medicaid managed care contracts, and it counts within the so-called medical loss ratio. It's not an administrative cost. It's a technology infrastructure addition or shift in the delivery of care that's intended to fill in the gaps in access to care and support the very limited availability that we have of great and dedicated but relatively costly healthcare professionals that contribute to making care better longitudinally for patients. It's technology. It's a pathway for technology support into the programs without even needing to do a waiver or a state plan amendment. And then rural health transformation. So $50 billion over 5 years. A lot of that, I think, is going to end up going to Texas and North Carolina because of the number of rural beneficiaries and because both states have come up with and submitted plans that are intended to be innovative and responsive to transforming rural health care. Looking ahead, CMS is also going to providing information technology infrastructure supports for addressing the challenges in the OBBA implementation. They're already piloting an app that I know a lot of legacy or long-term data infrastructure systems for doing eligibility in particular programs that are hard to update. CMS has an app now they're piloting in Louisiana and in Arizona New Mexico, I think, to enable beneficiaries directly to share, authorize sharing their data from IRS as well as from the companies like ADT that track employment in the gig economy, Uber, all of that growth, and send it directly to state and federal verification programs for having a job or having a community engagement requirement under the IRA, or re-verifying your income. Now these are not the early. It's like any early app. It's got its issues. People don't know about it. People may not trust it. So it's going to take some work to implement over the next year before the requirements for these redeterminations come in 2027. But if you look at the projected savings from Medicaid reductions in the OBBA, most of that is from these eligibility redeterminations and work requirements, where if you look at what's happened in the past, states have had real trouble implementing those effectively in a non-burdensome way that doesn't disrupt coverage. On the other hand, we've learned a lot about how health plans and social service organizations and other so-called ex parte sources of information can contribute to effective eligibility determinations, and technology can potentially help with that. So that's the opportunity. I would say that the new director of CMCS that's the Medicaid and CHIP programs at CMS, a guy named Dan Brillman, any of you know him? So yeah, Elena does. He's worked closely with us in North Carolina because he came from the private sector, running a program called Unite Us that basically is one of the private innovative companies that creates infrastructure to connect healthcare organizations that identify patients with social, other non-medical needs to community organizations that can help address those needs. So we have infrastructure building for that. That's who's running CMCS under the Trump version 2 administration. So some real opportunities there too around technology, around innovative models for making this work. Just briefly, a lot of opportunities, I think, to leverage the Rural Health Innovation funding. So this is a lot of money. Rural hospitals correctly pointed out, well, okay, $50 billion sounds good, but compare that to what's projected to be lost thanks to the limits on state directed payments and these other Medicaid reductions. That's 4 times larger. Well, that's going to be very tough to manage, but number one, the programs that you had in place were not sustainable anyway, and there are some good examples onto the right side of this chart of rural hospitals. Torch has been leading a good deal of this here in Texas. Rural hospitals that are more sustainable. It's kind of like a public health, population health hub with either backup or digital support to be more sustainable in the future for given the changes in demographics and these tightening fee-for-service payment systems. And with that, some opportunities to maybe scale that up with all this investment funds that are becoming available now. So some real opportunities, not going to be easy, but a lot of states are trying to figure out how they invest in infrastructure that can support more Medicare, Medicaid aligned payments. It's very hard to sustain a rural hospital today without Medicare and Medicaid alignment, and ideally some commercial help behind that. That's exactly what we're working on in North Carolina right now, between Medicare kind of innovative waiver for some rural hospitals, building on programs that I'll talk about in a minute, Medicaid reforms, and our state treasurer in North Carolina, largest employer in the state, for state employees, backing the same kind of program. So there's some real opportunities here too. I'm going to skip over this pretty quickly because you all know more about what's going on in Texas than I do, and the rest of the day is going to focus on these. But the state has had, thanks to the leadership of people in this room, an ongoing focus on addressing non-medical drivers of health, I would say from a public policy standpoint here in Texas, in North Carolina as well. Our legislators are trying to figure out just what non-medical drivers of health means. We've got this, on the one hand, kind of maybe a traditional Republican budgetary approach of like, hey, Medicaid should be about health spending. It's not, it's not SNAP, it's not HUD, it's health. On the other hand, the MAHA movement and the recognition that if there are ways of effectively addressing the contributors to poor health to chronic disease risk factors and their progression, we sure ought to support them, including food as medicine and the legislation that just passed in the past session. I've talked about rural health already, and thanks to Torch, and a lot of opportunities for transformation there. I know maternal health has been a high priority. I think your next session is on this, the recent legislation, so I'll leave that to you all. And it would say that the concepts that have been proposed in the Texas Rural Health Transformation Plan look a lot like what we are doing in North Carolina and what we've seen in some of the other states that we're collaborating with. The challenge is that Congress, in its wisdom, and this actually was wise, approved the legislation in July and told CMS that they had to award the whole $50 billion by the end of this year, which is a really short time frame for coming up with an application and then giving states a chance to put the application in and then making decisions about awarding that funding before December 31st, especially if you have a 5-week government shutdown right in there as well. Congress, I think, in its wisdom, because Congress knew that if they didn't award the money this year, come next year, there's going to be something else that will come along, and they will want to take that money for rural health transformation is related enough to whatever the challenge of the day is. So that money is going out to states. The challenge is that it is going to be a lot more work from here to figure out, within these broad goals, how to actually make it happen. So I think a lot of opportunities for building some infrastructure that can support, one of the things that I saw in the Texas application here is the importance of putting local communities first, because they know better than anybody else about what the needs are in the community, what the resources are to build on, the public hospital, the rural health center, whatever is there. So there's no way to do it without that kind of engagement and support. And by the way, all these social programs that I've talked about, connecting medical and social, they all depend on trust, and they all depend on supporting local community health workers and actually creating that workforce locally. So got to be locally driven, but you can't do it by yourself. The kinds of things that I talked about for paying in different ways, for data standards, for getting Medicare and Medicaid payment alignment, if every single community tries to do that on their own, it is just not going to work. So there's some work to figure out about how can you support at the state level the kind of infrastructure and training programs and data and aligned payment models that are needed and evidence on what's really working to help all of these programs scale. That's work that's still ahead of us. And then state-directed payments, I think I think they're going to happen, at least to some extent. Future Congresses may reduce these a little bit. You think it's bad in Texas? $2.4 billion losses overall, $1.4 billion to hospitals. North Carolina has even bigger numbers than that. We're the second largest number of rural residents in the country. And what I think people are starting to recognize is that we're going to have to use these rural hospital supports in a different way. And one of the areas where we've had the most progress in our non-medical driver health Medicaid reforms and related safety net reforms in North Carolina has been in working with hospitals to do what I talked about earlier, identify people who are likely to show up again in the hospital if they don't have a better, less costly, more prevention-oriented alternative, and intervene effectively to head it off. There is no way to fill the budget gaps the hospitals are facing, even before OB3, that rural hospitals are facing, certainly not after the state-directed payment changes, with continuing on with business as usual. It is a wake-up call for some fundamental shifts towards working together to prevent any avoidable hospitalization. And the good news is I think there are better ways to do that. We've had the privilege of working with many of you in this room, including the Baker Institute and Elena, both in her current job and previous jobs. I hope we can find some ways to work together to address some of these big challenges that are ahead. Let me just wrap up by giving you a few examples of what North Carolina has done. And again, there are other states that are taking these same steps, and there's some more opportunities and some more interest at the federal level than ever before in leveraging these to get through these very challenging times. As I said, we started with a waiver that was a Medicaid waiver that was approved under Trump version 1. Seema Verma was heading CMS, and President had people in his staff who were very interested in, you got to show this is going to save money overall, but we want to see reforms that include implementing coordinated health and social care interventions with measurable areas of focus on reducing complications and reducing costs, and a lot of attention to a data infrastructure to support it. One example of the kinds of pilot reforms that were implemented is a program called North Carolina Integrated Care for Kids. This was also a Trump version 1 pilot in 7 states. I think North Carolina and Ohio probably did the most in this program along the lines that I'm going to emphasize here, which is data-driven risk stratification. So this is a program targeted to high-risk kids, but with a family approach in mind. Why? If you're looking for high risk, if you find one kid in a family that's facing some of these social, non-medical risk factors, chances are pretty darn high that the other kids and the mom are facing some of the same challenges. So thinking about these as a family unit is a much more effective approach than thinking about just the individuals. And the moms, by the way, is a very strong argument, very cost-effective argument for more continuous Medicaid involvement for moms, and has been an issue here in Texas as well. What this program did was spend a good year getting going by integrating data systems. If you look at everything on the right side of this chart, that's a lot of stuff. And you might think, well, if your real priority is just paying for food, why are you going to all the effort and challenges of getting juvenile justice data or education data and legal service data connected in? They are incredibly helpful for the predictive models of rising risk families. What we found, and there was a whole lot of work that had to be done to handle this securely. It's done at the state level. The data doesn't come, any of the sensitive data doesn't come to us at Duke, even though we're very involved along with UNC in managing important analytic and administrative aspects of this program. The data is all managed at the state level, but it is, has been incredibly helpful in identifying risk factors like which kids and families are likely to end up in foster care, which, by the way, that is a huge predictor of higher medical spend, behavioral, other institutional care, not to mention worse performance in schools and other factors, and other early indicators like that. Which kids are not coming or not enrolled in pre-K programs? Which kids are not attending school? Which kids are, one of the performance measures in this program is kindergarten readiness for the pediatricians. That's something that they're supposed to track. And the data really helps identify these rising risk interventions. And then what this program did was it didn't actually create a lot of new payments for non-medical services for health. What it created a payment for was a care management program that was specifically targeted to these identified high-risk families to get in the support from social workers, the available, many of these kids and families were already eligible for programs like SNAP and things like that. We're not using them as effectively as possible. Everybody knows that these programs have limited resources and can work better potentially if they've got a good coordination across them. So this is really medical. The key invention here was medical social care navigation, putting it all together, including integrating juvenile justice and police. Some of the strongest supporters of this program are the juvenile justice law enforcement agencies, because it's given them a place, again, an off-ramp for kids that they can see on a wrong track with an opportunity for intervention. Cost $3 PM per month in the counties where it's implemented. I mentioned we're having those budget troubles in North Carolina right now. Because of the evidence that we had produced for this program, the health plans in the state said, we don't care if the state government's not going to give us the $3 PM, at least for the time being. We're going to continue this program. The providers involved in the program, same thing. It reduces their burdens too of poorly compensated complex care. The other program that I wanted to mention, and so just key points from this: data integration, rapid cycle evaluation, having ability to look at, run the predictive models as close to real time as you can. They're not going to be perfect. You're not going to get this right to begin with, but you can keep iterating and getting better. And if you can share those results with everybody enrolled in the program, they will work together to make that program work better and make it sustainable. So that is the path. This is not easy. Don't get me wrong, but this is the kind of path that I think can get to a sustainable health care. Our Healthy Opportunities pilots are a more financially substantive approach to paying for health in North Carolina. And this does, in the pilot areas where this was implemented, it does involve direct payments for food, nutrition services, direct payments for transportation, direct payments for some housing supports, direct payments for interventions for moms or people who are in unsafe environments at home to address that. We've done the same kind of rapid cycle evaluation there to show that this is very important, when the program is well targeted, not just paying for services for everyone, but when it's well targeted based on good predictive models of rising risk, these interventions can lead to fewer hospitalizations because everything from people who didn't have easy access to a primary care clinic will go to the emergency room if they have an urgent care need, to people who were having complications adhering to their diabetes meds or making lifestyle changes or things like that. Or just some temporary housing interventions, temporary, not replacing the long-term programs. Those lead to measurable impacts on unplanned hospitalizations and emergency department visits, and beyond that on net costs of Medicaid spending. We are still having trouble getting this program scaled up because this is not the default approach in Medicaid. The default approach in Medicaid is paying for sort of fee-for-service, long-term care and hospital visits and things like that. But this is on the map and is part of the kinds of challenge, the kinds of steps that are needed to get from where we are now to sustainable health care. And just to add to that, this program turned out to be incredibly helpful in Hurricane Helene. So this was one of our pilot areas, was right where those 4 feet of water got dropped. There was no communication, cellular of any kind. People didn't know where others were. And I can tell you from doing Katrina response, I'll finish after this. I think I'm going over, but I can tell you from doing Hurricane Katrina response, the problem in emergency response is the last mile. You can get in tons. We're really good at getting in, airplanes full and boatloads full of emergency supplies, meds, et cetera. The problem is, how do you get those supplies that last mile of people who need them, where like the federal government and FEMA, for all their advantages or disadvantages, they're trying, but they don't know this community that well. And we have emergency response programs in place. Texas has some really good planning systems involving the healthcare organizations and local governments, and we've seen that. So it actually worked pretty well in many of the COVID responses. But what you really need for something like this is those social connections. So no communication was working. The people out there, because they had established these social organization medical connections, would do like just community type meetings where we go down the list of like, okay, who is most likely at risk from not getting, from having their power out, from not getting access to, if we haven't heard from them, not getting access to medications or whatever. And they knew where they were. They had like the ATVs that could go up, into the hills, or the boats, because these are all local responders. I remember a story that the secretary of HHS for North Carolina told me at the time about going to a compound that was run by, I think it was the sort of a North Carolina regiment of people who were planning to be by themselves and not have interventions. And you probably don't want to go up there. It's not like, hey, I'm from the federal government and I'm here to help you. But because they had a community health worker who was helping people in that group that had diabetes, they had the connection. They were able to get them the assistance. So the Speaker of the House in North Carolina is from one of the districts that was most affected. And so he is now a strong, firm believer, and this is the way to do social care. But you have to build the data, you have to build the infrastructure, and you have to have a high level of humility that you're not going to get this right the first time, and just paying for non-medical drivers of health across the board is not going to be sustainable and is not going to be able to generate those kinds of numbers and then the stories like I just told to back it up. So this is one of the biggest challenges that I've ever seen in terms of helping to make safety net programs, Medicaid programs sustainable in terms of the environment we're living in now. But this is also the best opportunities I've ever seen for really changing healthcare, because again, it is absolutely clear that staying on the current trajectory is not going to work. I've talked about some of the steps that can help us move forward. That includes paying due attention with great data and keep trying to make it better, good analysis around how to address the non-medical drivers of health. It includes leveraging the federal supports that exist even now in Trump version 2 and MAHA for making rapid progress on this. I hope there are opportunities to do it. We are focusing a ton of our work at Duke Margolis on finding good examples from around states, promising practices, ways of doing this kind of rising risk analysis that are feasible and do work. So multi-stakeholder collaboration, rapid learning, and data and technology progress. This is a state collaborative that we're forming right now, and hope that you have some meetings this afternoon to see what can be done in Texas here, with a number of other states working with us already. I know this is not an easy set of challenges, but I sure am glad that you all are here, and it sure is a privilege for me to be with you today as you try to take on, I think, what probably the most important and the biggest opportunities for changing public and population health in our country right now. Thanks for the opportunity to be with you today. Yeah, I'd be any questions, and then you have to be on stuff that I talked about. It's like, what the hell are they thinking in Washington, things like that. Yeah. Yeah. Yes, that's a great question about it. Remember, I think Charles showed at the beginning, like there's everybody else in terms of spending and health outcomes, and then there's the U.S. way down over there. So what are the other countries doing right that we're not? I think that if you look at kind of the distribution of social versus medical spending, most of those countries have a very different balance than we do. And also, if you look at sort of the behavioral and social risk factors, we do relatively badly in terms of diabetes, obesity, overweight, things like that. I would say that that there are not very many high-income there are not very many countries, but high-income countries like the U.S. that feel like they're in a good position right now in terms of sustainable access to the kinds of care systems that I've talked about, strong emphasis on primary care, well-targeted interventions, recognizing we can't do everything for everybody, but with principles of equity and principles of efficiency working together, we can do more. I'd say that probably the Netherlands, where are you from? Yeah, I would say not the UK right now. So they're really struggling and having to hire like HCA to just backfill their hospital access problems, and primary care is pretty stretched. It's kind of a good foundation, but not yet. But I'd say not feeling like it's sustainable. The Netherlands has a really strong primary care system combined with good social care supports. Nobody there has problems with access to primary care or very more limited issues around specialty care, lower rates of chronic diseases. How you could bring that to the United States is a hard problem. But I say that everybody around the world is kind of struggling with, how do we make care less costly per person, more accessible thanks to technology, and more integrated around medical and social risks.
Okay. I think is the changing burden of disease, the changing demographic pattern. Do you see that as that will be managed within the system you're talking about and developing? Because it seems to me it's an enormous increasing burden, particularly Alzheimer's, dementia, obesity, things like this. And I wonder how you see that.
Yeah, it's a great question. So changing demographics, aging, and with that, definitely neurodegenerative diseases, and I get your point about obesity and behavioral change too. I think we've got an opportunity to make progress on obesity. If you look at U.S. statistics, we have hit a turn. There's been a downturn in the last couple years. I do respect to the MAHA movement. I think that's GLP-1s that are starting to have an effect. What we have not figured out is how to integrate drugs that can be transformative for obesity-related illnesses into a sustainable care model. But that is something that back to CMS, that they are really honed in on now, and that if you look at like some of the work from our institute, we think the best way to get there from here is to have a more, what we call and what CMS calls, and was in my title, evidence-based prevention, not just like hype and hope, but evidence-based. And there are now some good models of behavioral intervention programs that can be supported by technology. So, one of the few CMS pilot programs that really demonstrated impact on outcomes and costs is called the Diabetes Prevention Program. It was like a 2000s era program started by YMCA. So there's a mechanism in Medicare for basically paying for this intervention, a set of interventions around nutrition and exercise and lifestyle. Part of the payments for, well, does the patient keep coming back? The remainder of the patient for is, well, did you get to 5% reduction in BMI, or better control of hemoglobin A1Cs or things like that. Unfortunately, that program didn't scale. There were a lot of reasons for that. It was kind of isolated, not integrated with the rest of care. It's hard for people to go to. That program that CMS just announced yesterday, I think is you should view that as a digital version of the same thing. You know, something you can do at home with an app and with integrated data supports and with requirements to connect to your primary care provider. So that's a good foundation for, you know, you're not going to get management of these lifestyle and risk factors through our fee-for-service system with the primary care capacity that we have, which is going to get even more stretched no matter what we do in the next 5 years. It's like that's a 7-year, 8-year, time frame. So we need to augment our primary care practices and our community health clinics with technology. So this is an opportunity to do that. As good as the technology is, and I hope it keeps getting better, it is hard to change nutrition and lifestyle patterns without medical assistance. So GLP-1 drugs, I think, should be a key part of these kinds of programs. And so I was saying, if you watch what happens with Medicare and GLP-1 coverage, you might not have expected, based on what they were saying back in the summer, the CEOs of Novo and Lilly to be embracing a 75% reduction in their net drug and their list drug prices, and a 50% reduction in their net drug prices, down to, it's not quite NHS levels, but under around $200 per month per person. That is a number that is much more likely to get you to offsetting savings in at least high-risk patient groups that could benefit from those drugs. And there is growing evidence, I should say, that if you integrate GLP-1 coverage with a program like I was just describing, look at like Omada Health and others, these are private innovation, take private capital to build around our traditional fragmented, not very prevention-oriented healthcare system. You can get to adherence to drugs for a time period, maybe get some patients off the GLP-1s for the long term while maintaining weight loss. It is a great learning, like lose 5 pounds or 10 pounds and you couldn't before. That's a kind of a inspirational moment that behavioral health, behavioral econ interventions and things like that can help nudge people along with. So that's the opportunity to address obesity. And like I said, even without this kind of coordination, I think we're starting to turn the curve. You might say, well, Medicaid programs are really stretched right now. And if you look across Medicaid programs around the country, like North Carolina, first thing they did when we had this budget crisis past year is they canceled GLP-1 coverage for high-risk Medicaid beneficiaries. But thanks to these new pricing models, I think some states can get GLP-1s for like $80 per month. And if you can't figure out as a state, and a state working with your Medicaid plans and these innovative technology companies, how to make that cost offset for at least, high risk groups, BMI over 35, people with cardiovascular and metabolic disease complications, you're doing something wrong. So I think there should be opportunities to at least make progress in that direction. For neurodegenerative, I wish we had these kinds of transformative therapies now. There are many promising ones in process, but it's going to be the same thing there. We have to figure out how to get the prices down and get utilization of effective therapies up. It's going to take a different kind of care model than what we're able to do today, but hopefully you can learn a lot from making progress on cardiac, kidney, and metabolic disease, which I think can happen right now. All right, thank you all very much.
Is this one on? Okay.
How about this one? We're good? I think we're good, yeah.
Great. Well, this is another great session we have to look forward to. For some of us who are at the Capitol, visiting offices or giving testimony, you have some insights into how this process of policymaking occurs. But for those who don't have those experiences and just kind of see from the news items, what gets done in policymaking, it can be a little bit of a mystery. So we've got a real treat here today. We have a legislative staff member to join us and kind of tell us about the thought processes and the perspectives that they take when they're thinking about non-medical drivers of health. So I'm going to start off and let Mr. Diaz introduce himself and talk a little bit about his office and his district that he represents.
Thank you very much, Charles, for having me. Very excited to join you all here. My name is Alvaro Diaz. I'm Senator Johnson, Legislative Director, and I'm his primary lead on healthcare matters. His district is all in Dallas County, Senate District 16, and it goes all the way across the county on the west side from Irvin, goes into downtown Dallas a little bit, and then comes down on the east side around Richardson and Mesquite. So even though it's within just one county, there are a lot of different communities that have very different healthcare needs. Especially when you're comparing Irvin to Dallas to Mesquite to Richardson, Balch Springs. It's a very diverse community. So after he was first elected in 2018, Senator Johnson really made it a priority of his to address healthcare access and to improve the health outcomes of his communities. And which has led it has led him to filing quite a few healthcare bills. The primary one that he files every session is Medicaid expansion, and he has filed that in a plethora of forms, whether it is just a straight legislative directive to expand it. He filed also as a constitutional amendment, put it up to the voters because it's a wildly popular policy in Texas among the voters. He wanted to do also do it through a 1115 waiver, very similar to what Mike Pence did in Indiana. He called it the Live Well Texas program. And on top of that, once he ran into a brick wall regarding medical expansion, he started to think outside of the box. What else can we do to increase access, to improve outcomes and things like that? There is a very obscure bill that he passed in the 87th Legislature, 1296, that changed the way the Texas Department of Insurance values healthcare plans on the marketplace. That led to 350,000 plus Texans being able to find very affordable healthcare plans on the marketplace. And then these last couple of sessions as well, he has filed some sort of version of food is medicine, and then the bill that we filed last session in the in lieu of services bill that would basically allow MCOs to use what's already in place for substance use and mental health services within the HHSC, and then expand that to other services.
Great, thank you. So you've been very busy on health and health matters, and it was a really busy session. Record number of bills filed, which makes it tough for them all to get through. So we had a relatively low overall passage rate. But if you look at the bills that focus on non-medical drivers, we actually had a pretty good success rate. We beat the overall passage rate. We had 12 bills filed. They kind of fell into two main categories. One was about provider types. We had a handful of doula bills. We had a lactation consultant bill go through. And then the other group was this issue that you were just mentioning, in lieu of services. We had a handful of those bills come through, but yours was actually the first to get dropped, and also the broadest of the bills. So tell us a little bit about what was in SB 236.
Yeah, absolutely. So it was basically a simple change or addition to what's already in place, like I mentioned before. When we were looking at in lieu of services bills, we kind of took it a two-pronged approach. We were very intentional with which services we wanted to cover. We also filed in conjunction with Representative Oliverson in the House a food is medicine bill that was definitely targeted to that particular non-medical driver of health. And then we also said, why don't we swing big? And we looked at what was already available. We talked to the state agency, and the state agency had already put out their non-medical drivers of health action plan. We looked at that as well, and we found the sections of code that allows for in lieu of services for mental health and substance use disorders. So we said, why don't we include other services in here? So the bill is incredibly short. It's 1 page. It's 2 pages if you include the boilerplate language at the end. That's the effective date and whatnot. But it basically just adds. We use terminology that was suggested by the agency. That is non-medical health-related services, and that was what we included in the bill's language to say MCOs can provide. It has to be evidence-based. It has to be cost-neutral, and it is up to the MCOs also to provide the reporting that says this is actually effective. So it have to be effective, have to be cost neutral, and have to be evidence-based to provide all the services outside of just mental health and substance use disorders.
And for this bill, like you said, you kind of went big and gave the agency, some leeway in how they wanted to think about it. What we see in legislation lots of times of what's the difference between success and getting stuck sometimes is just how you scope the size of that.
Correct.
And there was a really, I think, interesting debate between your boss and Senator Colkhorst during the session that was just talking about that issue of how to size things. So I'm going to just play this clip right here.
I think that House Bill 26 is another one of those. This particular amendment in lieu of services, and we have 14 of the 16 MCOs that are actually doing some in lieu of services. What I wanted to do was to focus this on a certain population in Medicaid. Let's see if it works. Let's get the data back, and then we can apply it to all the populations.
So, Senator Colkhorst, I urge members to support your amendment, and I would urge you to accept my amendment to take it back to the House version. But I know that you want to take a slower approach, get some information first. I think we would do better to allow the Commission to have the discretion to deploy this mechanism more broadly than this very, 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 very narrow circumstance, and rather than explicitly prohibiting them from doing so. But I appreciate that you're taking this step, and I hope it will be the first in a series of steps that we finish up next session.
I agree with you, and I like to incrementally move things in a direction, especially in Medicaid, and I've said this many times. Article 3, which Chairman Creighton, Senator Creighton has worked on, and Article 2 are the largest parts of our budget. They cover nearly 80% of the budget that we spend here in all funds.
Very expensive.
And so we're looking for a way to bend the curve, and you have to bend that curve with data. So I understand what you and Dr. Alverson are about. I want to be very pinpointed and say, let's see what this does. Let's see how it rolls out. We'll be back here in unbelievable, if the voters allow some of us to come back, we'll be back here. We can look at that data and see how we move forward.
Thanks, Senator Colkhorst.
So I thought that was a really interesting moment there, just to kind of talk about how quickly can we move. And I'm just struck by the contrast between Senator Colkhorst's position and just what we heard from Dr. McClellan, talking about just the pace of change, and that the track we're on is so painfully unsustainable that we've got to move quickly, So I think Senator Johnson was, making the case for, moving more quickly. When you meet with other offices or committees and you talk about, the size of and the rapidness of the movement, what's the pushback or the kind of counter arguments that you get?
Well, first of all, I want to say that I'm going to save that clip because I want to make sure that Senator Johnson plays it back to Senator Colcourt's next session. And it's like, hey, remember what you said about this, that you were going to look at it, and that we're going to move forward. I will say that it's a different experience for us being a Democrat office in a Republican majority legislature. The burden or the bars that we need to meet in certain aspects are a little bit higher, especially when it comes to costs. One of the things that we really have to be mindful about, a lot more so than our colleagues across the aisle, is a fiscal note. Fiscal notes will sink any bill, especially Democrat bills. So we have to keep in mind while we're having conversations with other offices and with our colleagues, with folks in the committee, with the committee office, to really drive across the point of like, these are interventions and services that are meant to reduce the cost of healthcare, and drive home the point of preventive medicine's role in reducing costs of healthcare. The challenge that I find most often is trying to convey the effectiveness of preventive healthcare in reducing costs, because it's really hard to make an argument with someone that may not be as versed as we all are in this room when it comes to non-medical drivers of health, of how there is not a direct line of, we provided these services and it saved us this amount of money. It's not that, there's not that linear path. And when you're trying to explain that to the committee office and the staff and the members of the committee, it gets a little murky, and then you end up with interactions like we just saw in the clip, where Senator Colcourt is a little more reserved in implementing these programs, because she wants to keep the costs low, gather the data, see if it's working. And it also reflects a lot of the attitude of state leadership towards the Medicaid program and the things that are offered through Medicaid, that it is very targeted to pregnant women, children, and people with disabilities. It is true for the Medicaid program overall, and it is it reflects in some of the smaller approaches like food as medicine.
For sure. And I think that another issue that I saw during the session was a discussion about, well, what's the role of Medicaid when it comes to food versus the SNAP or WIC programs. And we're producing a report right now that'll come out in the new year that kind of delves into like the real differences in those funding streams, the data, who's eligible for those and what kind of services they can get. So how did you see that issue of WIC and SNAP kind of confusing maybe our discussion of how Medicaid might consider providing food?
It's definitely, it definitely will take a little bit of educating legislators in the difference between the two, the different funding streams between the two, because the members of the committee may be a little more knowledgeable. Those outside of the committee, it's going to be a little bit harder to explain that to. I would say that conversation it's going to be not difficult or anything like that, but one that's necessary to have to explain what is Medicaid's role versus what is SNAP's role and things like that, and who qualifies for one or the other. Sometimes, obviously, in Texas, just because of the way the Medicaid eligibility is, a lot of the folks that qualify for one qualify for the other. So that's going to be a conversation to be had. This past session, one of the biggest, or not biggest, but one of the most consequential SNAP bills was Senator Middleton's bill that restricted the way in which you can spend your SNAP funds. It will be interesting to see if there are any healthcare fallout from that bill, or any following the usage of SNAP benefits that could maybe also inform the conversation of what's the role of each program moving forward. I would say that it is also, the role of organizations like yours to educate, come talk to us. One of the biggest things, I used to be in research before transitioning into policy. Nothing crazy, just lab manager for neuroscience labs. And one of the things that pushed me towards policy was the gap between research and policy. And bridging that gap is what it's going to definitely move this conversation forward of non-medical drivers of health, and what is the role of all these different policy ideas that we have that are evidence-based, and how we turn that into policy.
So in bridging that gap, some of the groups that we have representing our audience here are rural advocates for the food bills, and that was, there's a lot of activity on food, and you mentioned HHSC's non-medical driver action plan. Food is one of the components, but it also is transportation and housing are other priorities that they have, and those other ones didn't quite get as much attention as food. What do you think allowed food to kind of be so popular this session?
Yeah, absolutely. So in my conversations with my colleagues and things like that, the reason why food is, I wouldn't say far ahead, but the reason why food is an easier angle to tackle this non-medical drivers conversation from, it's because you can make the connection between food and chronic disease a lot easier than you can do it with transportation and housing and so on. So because of that, it's easier to say, okay, food to health, it's an easier path, an easier conversation to have, an easier topic to explain, because people will understand diabetes, and making that connection works. In my conversation of the in lieu of services bill, I was trying to make a different connection, which was, for example, home remediation programs. Asthma, it's one of the leading causes of why, if not the leading cause, why kids stay home and miss school. A lot of the sources of that, or what causes the asthma, could be traced back to the environment in which they live in, a moldy rug or just anything in their house. So allowing MCOs to pay for maybe a carpet replacement or just home remediation, just to identify the triggers and solve the triggers at home, can reduce the incidence of asthma. The kid continues to go to school, not to the emergency room, things like that. And having that conversation, I definitely saw a lot more blank stares. It's like asthma to how do we, if I pay for a carpet replacement, are we remodeling their house, what's going on? I'm like, no. We're just identifying the triggers, solving the triggers, so the kids don't end up in the emergency room. Saves us money, because a lot of the Medicaid population are children. So if we're, it's interesting because, like, going back to like the things that I have to say to our Republican colleagues or the state leadership revolve around how are we saving money, which it's not the immediate goal, not in my eyes, not in Senator Johnson's eyes. He'd rather have improved outcomes, not regardless of what the cost is, but if we're seeing the return of investment, then he's like, okay, if it's cost us that much, but we're seeing the improvement, fine. Whereas I feel like sometimes I'm trying to approach things as like, okay, it's gonna save us this much money, please let us do it. But yeah, so back to your original question, yeah, it's just easier to see that connection between food and healthcare outcomes.
Which makes sense. Well, kind of looking forward in the crystal ball, what are you predicting for the next session? What's your office kind of preparing for during the interim period? What's next?
What's next is continue to build upon the Maha movement. We are grateful that this is where we're at with the conversation of making Texas and making America healthy again, and we're trying to really take advantage that conversation revolves around nutrition and revolves around non-medical drivers of health. I think this is what we saw this past session was a good first step, maybe not the leap that we wanted to see based on legislation that Senator Johnson filed, but it was a conversation starter. It was, a lot of people are now paying more attention to nutrition, and that is going to be our gateway into addressing other non-medical drivers of health, transportation, housing, just general infrastructure. When we're building out communities, are there enough parks? Are there enough sidewalks? Are people empowered to be active? What are the houses looking like? Is there asbestos on the walls? All of these things can now be pushed. Hopefully the nutrition conversation drags all of these things forwards as well. And we will most definitely come back with the same in lieu of services bill next session. We will probably file our food as medicine bill as well, along with Representative Oliverson. We also have a health literacy bill that I believe also it's part of this entire ecosystem because education and healthcare go hand in hand. Folks that are better educated have better healthcare outcomes, especially when they're educated in health and they understand the mechanisms that affect their health, and they can make better choices that way. That's another bill that it has passed the House multiple times, the health literacy bill, multiple sessions, gets stalled in the Senate every time, and it's trying to figure out ways in which we can link that conversation of health literacy with cost reduction, better outcomes, and so on. Because what Senator Colcord said, it's very, very true. Our Article 2 and Article 3 take the majority, by far, and it's not even close, the majority of our state budget, and we might not enjoy the same size surpluses that we've seen in the last two legislatures moving forward, and there are other financial commitments that the state has made that we're gonna be paying into for many years to come. So it's also having those conversations like, where do we want to prioritize our dollars moving forward?
We've been fortunate that we've had a surplus these last couple of sessions, and
Right.
when that's no longer true, that price conversation gets a lot more challenging. If anybody has any questions, just raise your cards up. We'll have somebody come around and pick those up. We're getting close on time. So you're talking about expanding beyond just food and to some of the other non-medical drivers. The other concentration for the last 2 sessions has been applying these tools or services for pregnant women. You know, what's the next priority population that you think there's an appetite to, apply these services for?
Children. So if we look at where the state Medicaid's priorities are, just in the program in general, pregnant women and children. So children would be the natural transition to apply these programs to. I would really like to see a food as medicine program for children specifically. That would be the easiest way to pivot from pregnant women to children, and that would be a easier conversation to have with the Health and Human Services Committee. It's like, hey, we did it with, we have a pilot program. Hopefully that data comes back and it validates all the points that we've already been making. And we can say, okay, now it's time to expand it. It might not be wide open to everybody quite yet, but if we go from, next session is expanded up to children, and then people with disabilities, and then we continue to grow it that way, that would be probably best case scenario. Unfortunately, as we've mentioned before, policy at the state level, even though it moves faster than the federal level, it's still painfully slow. And it may take 2-3 sessions before we see a comprehensive change. It would take, it usually moves faster when there is like an absolute catastrophe, which short of our entire healthcare system collapsing, I don't think they're not gonna be like, oh, this is the thing that's gonna fix it all.
So we just need a good emergency.
Yeah, exactly.
LL, did you have a question?
I think a lot of the times we run into political barriers more so than lack of information, lack of data. And it has to, so for policy to move forward in a meaningful and time-sensitive manner, like the perfect storm of things have to happen. We are looking out, or that the conversation at the federal level is moving towards nutrition and non-medical drivers of health. And a lot of the times, the Texas Legislature will reflect what's happening at the federal level. A very big example of political barriers is Medicaid expansion. If you poll the voters, and if you put it to the voters, we would have expanded Medicaid a long time ago. it hasn't happened because of political barriers. One of the reasons why we call it non-medical drivers of health now and not social determinants of health, it's, again, just the perception at the perception of policy, we don't necessarily like the word social. Be it as it may, we are adapting, and we're trying to figure out the ways in which we bring the data that we already have, the data that Senator Kolkos, for example, would like to see, and say, we already have this, it's here. It's just tough when you have to fight with data and evidence against an ideology. You're doing apples and oranges at that point, and it's hard to break through. But sometimes the political winds change, the political environment change, and it aligns with what we're trying to do at the policy level, and that's that missing part. It's making sure that thing, and sometimes you've hit your head against the wall enough times where you starts to crack and you break through and you're like, finally, it only took me 3-4 sessions, which in Texas is 8 years, and you make it through. And it's also, we can put up 100 papers that say no medical drivers of health, reduce costs, and then anyone that opposes that idea can find the one paper that says and that's it. And it's like 100 to 1. I'm like, but look at all this, and it just doesn't matter. So it's not easy. It's frustrating most of the time, but it's our job, my job as a staffer, my boss's job as a legislator, to find the little creaks and the little ways in which we can inch things forward until they get to the goal.
Well, you've alluded to, the state lots of times looks to what's happening in DC for, direction on some issues, but, states truly are the incubators for policy. We can be much faster and more innovative at the state level, and we've been enjoying some great success due to the work of Senator Johnson and others on these non-medical drivers. So thank you for the work that you're doing, and thank you for sharing your perspective with our audience here today. We've got a short break. There's some drinks out in the lobby, get a refreshment, but be back in here by 11:15. We've got another great session. Elena's moderating our advocacy panel. Thank you.
Thank you.
All right, let's get ready. We have one more excellent panel session, and then we're going to have lunch, so you'll have more time to talk, because I know that half of the reason we all come to these things is because we want to talk to each other, and we want to make sure there's time for that. This is going to be a fantastic panel. So you just heard from Alvaro about what it's like being on the inside of the legislature and how he and his boss and their colleagues navigate all of this stuff. And those jobs are really important. But behind the scenes, before and during every session, there are advocates from across the state who show up to educate the legislators and their staff members, and who really do the work of making sure that bills get massaged, that they understand the ins and outs of what's being proposed. And it can be really thankless work. And as you've heard people say before, nobody likes watching sausage making like they don't like like watching the legislature in action. But if you don't understand how policy is made, then you really can't change policy or impact it. And so today you're going to have the treat to listen to three people who spend a ton of time walking the floors of the big pink building, trying to make sure that we actually get policies developed and implemented that improve the health of Texans. And so let's get to it. Y'all are sitting in a particular order, so we're going to go on in that order. I'm going to ask each of you to tell us who you are, tell us who your organization is, and then if you'll start with just the big picture issues that you covered this session. We'll move into the NMDOH stuff later, but let's talk about the overview of all of the issues that you worked on in the health space this session. So, Laurie, take it away.
Thanks for having me here today. I'm looking forward to this conversation. And I missed you two. We spend many hours together during legislative session. So it's nice to see you again in person. So I'm Lori Van Hoos. I own a lobbying consulting firm called Treaty Oak Strategies, mainly focused on Medicaid policies, healthcare policies, and do a lot of work around non-medical drivers of health. This last session and for the past two sessions, I've worked very closely with the Episcopal Health Foundation on advancing their priorities within the legislature. And so one of the main things that we worked on, I know we're going to talk about non-medical drivers of health here in a little bit in House Bill 26, so I'll wait until we get to that part of the conversation, but talk about some of the other things. Episcopal Health Foundation is really focused on changing the narrative around diabetes. We spend a lot of Medicaid dollars, hundreds and hundreds of millions of Medicaid dollars, billions of Medicaid dollars each year on treating individuals that have diabetes. So EHF is really focused on prevention. How can we shift the narrative and the conversation from treating diabetes to preventing diabetes? So you heard Dr. Mark McClellan talk about the diabetes prevention program. We were able to get a budget writer put into the budget that will require the state, the Medicaid office, to study the feasibility of implementing diabetes prevention program here in Texas. If you're new to the legislature, one thing we try to do is find ways to get direction in the budget, because the budget is technically, per the Texas Constitution, the only bill that has to pass the legislature. So if you get your thing into the budget, you have a better chance of it getting passed. Bills are hard to pass. Budget has to pass. It is hard to get a budget writer, but if you can get it in there, you can make more ground usually than a budget or a bill sometime. The technical part of it is, though, you can't make state statute. So you can tell the agency to study something. And so we're hoping the agency will study this, we'll have some data. We can then go to the legislature and ask them to add that as a benefit in the future for the Medicaid program. I also worked on the lactation consultant bill. You may remember several sessions ago, we were able to successfully get 12 months coverage for women in Medicaid after they deliver. Before, they only had 2 months coverage. Now they can get coverage for 12 months. Very important to be able to address some of the maternal mortality issues. And so we're working with Chairwoman Hall, who's Chair of Health and Human Services in the House, and we were like, okay, we've got 12 months. Do they have all the supports they need? We found out that Medicaid wasn't covering lactation consultants. You could get a lactation consultant if you're at your doctor's office, but not a standalone benefit. So we were able to pass that as a standalone benefit, and that'll be a provider in Medicaid here in the near future. Also worked a lot on House Bill 18, which is the rural health grants. You've heard about the OB3 $50 billion in rural health grants that are going to be going out to rural hospitals and providers. We were able to get a bill passed in Texas before that, which interestingly enough has a lot of the same language that's in OB3, but we were first. That'll give $50 million in innovation grants to rural hospitals. And then finally, one of the big areas I work in addition to the non-medical drivers of health with Episcopal Health Foundation, is the Nurse-Family Partnership. I don't know if you've heard of this program, but it's a great program that pairs first-time moms that are high risk with a nurse, and that nurse stays with them through the second year of the child's birth, helping ensure that they have connections to social services, to non-medical drivers of health. They're going to their doctor's visits. They know how to take care of their child. Great results from that program, and we were working on getting that fully funded, and we were able to get it fully funded. Didn't get a pay raise for those wonderful nurses, but at least got it fully funded, so that program will continue here in the next 2 years. So many other things, but I'm going to go ahead and pass it over to Daniela.
Hi there, my name is Daniela de Luna Olivares. I am the Deputy Director of State Affairs with the Texas Association of Community Health Centers. So we represent the 79 federally qualified health centers in the state of Texas that provide medical, behavioral, pharmacy, vision, and also provide a lot of social supports to Texans throughout the state. And so we track a lot of things, as you might imagine, covering all those different kind of subjects and spaces. One of our key priorities was the FQHC Incubator Program. So that provides funding for health centers to allow them to add more doctors, physicians, PAs, community health workers. It also allows them to take on capital projects and all other infrastructure. And so that really has been helpful in the last couple of sessions, just to continue to expand our footprint, knowing that we are a big safety net provider. We provide coverage to patients that have Medicaid, Medicare, and also the uninsured, as well as those with commercial insurance. So we rely not just on that kind of program to help sustain operations, but also on other big programs like the women's health programs. And so we're part of the Women's Healthcare Coalition, and we track a lot of those services to allow women to continue to receive access to primary and preventive care coverage. Other areas that we also participate are in the workforce space, and we were involved with changing some of the requirements to increase the eligibility for the mental health loan repayment programs as well. And another key top area for us was the 340B, just making sure that we continue to have access to affordable prescription drugs for our patients. So lots to cover in a short amount of time.
Hi, everyone. My name is Jamie Olson, and I'm the Vice President of Policy and Advocacy with Feeding Texas. Feeding Texas is the state association of food banks. So we have 20 food banks that collectively serve all 254 counties in the state. And we, as you can imagine, advocate on all things related to hunger and food access. I work a lot on SNAP, the Supplemental Nutrition Assistance Program, as well as pretty much any other federal nutrition program, including school lunches and WIC. This session, we were able to increase funding through a budget rider to eliminate the reduced price program in school lunches. We got it passed for breakfast 2 sessions ago, and then this time we're able to expand it to lunch, which just means instead of there being a tier for some kids eating free and some kids paying a reduced price, now there's state funds to cover that reduced price, so more kids are eating free in our public schools. So really proud of that one, in addition to HB 26. And we also advocate on what we call the root causes of hunger, because we recognize hunger does not occur in a vacuum for families. It's a symptom of a broader economic challenge. And so we have pillars in the root cause category around healthcare access, housing affordability, financial security, and local food systems.
So from the outside, it looked like the last session was all about school vouchers, and then I think there was some THC kind of stuff. And in the background, we were watching the Trump administration come back into place, and we had the MAHA movement, we had federal funding uncertainties. And so as you looked at the legislative session last year, what did you see, not necessarily what you were interested in or advocating for, but what stood out to you as these are the big issues in the health and healthcare space that they're looking at?
I will say there's continued conversation. We hear it more and more each session around the need to make healthcare more affordable. You have quite a few individuals that are legislators that also own businesses, so they feel the pain of having to provide insurance for their employees. Lots of conversations. We still haven't got there yet, but always a constant conversation about how do we make healthcare more affordable. So that conversation continued. Like you said, the Make Texas Healthy Again bill really was a huge focus when it comes to healthcare. That was what a lot of attention was put on. That and then the rural health care bill that I talked about earlier that was giving funding to rural hospitals because we have so many rural hospitals that are having to close their doors. So what can we do to increase access and also make them more sustainable? What was interesting and kind of one a little bit behind the scenes, unless you're really, paying attention, there's a Texas Pharmaceutical Initiative that was started a couple of sessions ago. It got expanded for another 2 years, and what that group is doing is it's looking at how can we make healthcare or prescription drugs more affordable? Can we combine different programs? Medicaid has rebates. Can you leverage Medicaid pharmaceutical initiatives to make, employer-sponsored insurance more affordable? So really looking at the cost of pharmacy. So that initiative has been extended for another couple of years as they continue to study if there's options here in Texas for us to identify ways to reduce the cost of prescription drugs. And then another really interesting conversation that was going on was AI. And we heard a little bit about it earlier. There was a big AI bill, and healthcare ended up not getting put into there, but there's a big conversation around, I think this is going to continue, and we're seeing it in multiple states and at the national level. And I think what's going to be interesting is you're going to have different states that have different rules around what you can and cannot do with AI when it comes to healthcare. So that discussion was started. It did not end up in the final AI bill, but I think it's going to continue to be a conversation when it comes to healthcare. But it was pretty quiet in the Medicaid managed care space, which usually is a huge conversation. It was really just conversations around procurements and contracts and less really about the managed care model this last session. But we are going into a sunset, and we'll talk about that here in a minute. I think managed care is going to be big in the upcoming sessions because of sunset.
Yeah, something to add to that. It was pretty much every Health and Human Services hearing had chronic disease mentioned over and over again about the high cost of chronic disease in children, in pregnant women, in older Texans. And so looking to see where we can help fill in those gaps along with maternal health. It continues to be a hot topic given just the ongoing data trends that we're seeing in the state. And we did see a couple of bills aimed at targeting addressing those maternal health issues like the lactation consultation or the doula bill for that, as well as for us tracking the impacts of the Medicaid unwinding and the loss of coverage for a lot of, especially children, that after the public health emergency lost their Medicaid coverage because of a lot of administrative challenges in that process too.
Yeah, so I want to talk about a couple of our things. So one of our biggest priorities this session was Summer EBT. Summer EBT is a national program that was started brand new a few years ago that unfortunately Texas does not participate in currently. It's designed to feed kids while they're out of school during the summertime and they're missing those healthy free breakfasts and lunches that we just talked about. And it would bring $450 million to Texas every summer to feed approximately 3.5 million Texas children. So it's a huge economic win for the state too. And we were able to secure the $60 million through a budget rider that was necessary in order for HHSC to get that program up and running. And the governor ended up vetoing it. Because of the uncertainty that was happening at the federal level. This was while the One Big Beautiful Bill was being drafted and debated in Congress, and ultimately it included a massive cost shift to states for the SNAP program. States will be responsible for paying anywhere between 0 and 15% of the benefit cost of SNAP starting in FY27, and if you look based on what the state's payment error rate is, I won't get into too much detail on what that is, but Texas could be on the hook for up to $715 million per year just to keep SNAP whole and operating. And so that is enormous, and I cannot understate that it is a massive shift in the structure of this program that states have never had to deal with before. In the entire history of SNAP, benefits have always been 100% federally funded. And so while that uncertainty was playing out, it created conversations at the legislature about, well, how can we possibly, take on additional costs to start a new program like summer EBT if we're going to be responsible for paying so much for the existing program. And so these conversations certainly will continue into next session as we look forward. Yeah.
One thing I wanted to add too is we do a lot of work together playing defense. So I think we're talking about the good stuff that we passed, but we do a lot of work on defense. There's some bills last session that would have drastically impacted the ability for us to have good and strong eligibility systems. So when people go apply for SNAP, go apply for Medicaid and other benefits, we did some work on stopping some of those bills. I'm trying to think, there's a lot of bills that we work on just trying to either make better or just completely keep from moving. And a lot of it's just these legislators that we're working with, this is just a part-time job for them, right? They are not subject matter experts in all of this, and so they may have ideas that they think are good ideas, but when you put them into practice and implement them, they're going to have major negative impacts. So we do a lot of work of language changes, and maybe not be a bill I'm working on, but one of them will bring it to me and say, hey, this bill, do you guys want to get behind us and help us go, hit certain offices and educate them on the impact this will be. So I would say 75% of our time is defense, most sessions.
Yeah, and it will certainly be next session too, with the renewed focus on SNAP, I'm sure.
So let's turn specifically to NMDOH, and we heard from Alvaro. There were a handful of in lieu of services bills filed. There are a bunch of different food as medicine bills, et cetera, et cetera. HB 26 got passed. Most of the others died. So tell us what was going on behind the scenes from your perspective and what you saw advocates doing to shape the conversations to help or keep things not being as bad as they could have been. What do you know that we all don't know because we weren't there in those corridors?
And if we start twitching, I apologize. PTSD on this one. So I think over the last several sessions, there's been a conversation around how can we improve the health of individuals on Medicaid by ensuring they have access to healthy food. There's been bills filed that would have created big programs, 1115 waivers, what they were called, 1115 waivers, which you saw Dr. McClellan talk about, that's taking place in North Carolina. That's a big lift to get an 1115 waiver put in, and it also has a huge fiscal note associated with it. And also, as we heard the discussion before, if you got a fiscal note on your bill, it's highly likely it's going to be much harder to get passed. So I would say over the interim, we've all worked together, everyone that was invested in making some kind of movement, talk about what can we get passed and where should we go. And I find with the Texas Legislature, we have to take baby steps, little bitty baby steps. And so we all agreed that if we could get an in lieu of service bill passed, it won't have a fiscal note. In lieu of service means in the Medicaid health plan contract, they can offer a in lieu of service, a specific service in lieu of another service or another setting. So for example, I can offer food in lieu of potential low birth rate baby. So it's in lieu of service. It has to be more cost effective than the actual service, and it has to be clinically appropriate. So since it's cost effective, it doesn't have a fiscal note. So this was a way for us to get it across the finish line because it had no fiscal note. It had,
we keep talking fiscal note. Somebody tell this audience what a fiscal note is for the people who don't know.
So when a bill is filed and it's going to get a hearing, it goes to the Legislative Budget Board and to the agency that'll be impacted. I had to do fiscal notes when I was at the Health and Human Service Commission. We get a 24-hour turnaround. We have to come up with all the costs that it's going to take us as the state agency to implement that. So if it's a new benefit, if we were going to offer it, instead of a lieu of service, an actual benefit, how many people would access that benefit? What would be the cost of that benefit? How would that increase the cost of the Medicaid program? How many staff am I going to need? Am I going to have to make system changes to the eligibility system? It's a huge, cumbersome thing, and it's quick, and you come up with the cost associated with implementing that bill. So this would not have a cost because it's a substitute for an existing service. So we did not have a fiscal note. It didn't have a cost associated with the bill, which means there doesn't have to be a debate on oh, we're going to increase the Medicaid budget. Oh, we cannot increase the Medicaid budget. Your bill's dead, which is usually what we run into.
But it didn't pass as an ILOS.
It did. So there's a lot, there's a long story. We'll see, figure out how. So basically what it came down to was there's an argument from some legislators that Medicaid should not be paying for food. They don't like the word food as medicine, unfortunately, and that may be another word we have to figure out how to change in addition to non-medical drivers of health. But there is a debate, which is also interesting because we're also in the process of making Texas healthy again, which was all about healthy foods. But we don't think Medicaid should be paying for food, is the debate. So what we ended up negotiating in different versions and different processes and different, ways was a bill that allows us to offer nutrition counseling as an in lieu of service without the food. And then we made the argument, well, you've got to have the food. So they have also added in last minute negotiations the medically tailored meals. So you will do a pilot on offering medically tailored meals as an in lieu of service as well. And the goal of that pilot is then we can demonstrate, as you heard Chairwoman Colkhorst say there, I want to see the data to show it has an impact, then potentially we can get it as a benefit. This is what you do, unfortunately, sometimes with these pilots, which are painful, to get us the data we need to show and make the case that you should be paying for medically tailored meals as an in lieu of service.
Even though there's already plenty of data on the topic.
Yeah, and to add to that too, when Lori says we would get together, it's like sometimes we would jump on a call on a Friday afternoon the week before a hearing just to make sure, like, are you okay with this definition? Are you okay if we just target this population? If you look at the bills from previous sessions, they're a lot more specific. They're a lot more specific about service areas, about which services specifically, and sometimes as advocates, we need to be able to go broad and just kind of have some wiggle room so that then we can play along and kind of navigate things as opposed to saying, I want it in this area to mean this and with only these provider types.
Yeah, it truly is a negotiation, and I felt like this session I had whiplash watching, first it was the Oliverson bill, then it got changed to 26, and then it was the amendments back and forth on this bill to get it to where we ultimately got. And I am very grateful that the pilot was ultimately included in the bill, but to your point, we have so much data and we provided that data to the legislature, to the members, to the committee staff, to show that food as medicine interventions are cost effective and have, affect better health outcomes and all of these things. And so I do find it a little bit interesting, watching that clip and hearing from Senator Colkhorst, like, hey, we need to do a pilot to see what the data says, when you look at the other pieces of the MAHA sort of legislative agenda, and there are a lot of things that are not evidence-based in that agenda, some of which, we pushed back on, some of which not so much, but, changing red dye in Swedish fish isn't gonna make anybody healthier. But we move forward with bills banning certain ingredients and SNAP restrictions, also no data to support that, but we hear we need the data in very selective circumstances, I think.
And we did get to a point where we did discuss, do we even continue to push this bill if it's only going to be nutrition counseling? If we're sitting there talking on a Friday night, do we kill our own bill, right? Or do you take what you can get? Because, we just didn't feel like it was there. We had a version that passed the House that included several food provisions in it. We were able to get that added in as an amendment on the floor. So we get it out of the House and we're very excited. We have a full bill that we think really is going to get us where we need to get by allowing the nutrition counseling paired with, food programs. And then it got stripped in the Senate. And, there was a lot of trading going on. The Make Texas Healthy Again bill was being held up by big grocery stores. They did not want to have to label their food. And there's some pretty big, powerful grocery stores that we all love, but they were fighting it along with some others. And so there was concern that bill was going to die. And then there was they were holding the in lieu of service bill on the Senate side, and they were holding the lactation consultant to get that bill out. So we went and, on a Saturday, printed out flyers and went to every single House office and said, vote yes on the Make Texas Healthy Again bill. Get it out, get it out, get it out. Because we knew if we went and did that, it could help us with some of the other stuff. So sometimes you have to jump on bills and go advocate for bills, not even your bill, or anything you really, were working on, but to get something unstuck somewhere else. So there's a lot of moving parts, and it's a lot of us calling each other, and what have you heard, and where is this bill, and how do we get it unstuck at this point?
On 26 specifically, I wanted to shout out Carolina Cano from the Houston Food Bank over there. Yes, she should be sitting up here. Honestly, I did not. This is, as you can tell, like every time a bill passes, there is a huge coalition of different organizations, different advocates behind it. I did not do this alone. She did so much work over the last 2 sessions educating members, because I think it's been mentioned a couple times, but that fundamental thought of like, Medicaid shouldn't be paying for food, that was kind of like the first hurdle we have to get over. And then I think another tidbit about the concept of medically tailored meals or medically tailored groceries is the sustainability and sort of the off-ramp, right? So like, how long is that intervention meant to be for that specific patient? And once you stop providing the medically tailored meals, what happens then? Is there, lasting change in that person's diet? Is there, kind of an off-ramp from maybe medically tailored meals to kind of a prescription grocery box, and then ultimately to self-sufficiency? And so those were a lot of the conversations we were having also.
The other question that kept coming up was, how do I know if Medicaid is paying for the pregnant woman to get the food, that the pregnant woman is not giving it to other people in the household who are not Medicaid recipients? That came up over and over and over again. And because, of course, how did we,
Well, and that was also another common thread throughout the session, was this emphasis on fraud, waste, and abuse, and on program integrity, and where are taxpayer dollars going to. And I think that for other organizations and these as well, we tap into our community networks to say, give me examples. And so we have people that would go and testify or submit written comments to say, here's a story about this woman, this family, here's a story about our program and how we make it work. Because unless you're familiar with how they operate, you really just come up with ideas, or you go with whatever's available to you at the Capitol, and it's not always coming from the same side.
To answer that question, we just go back to the data, and it shows that when this has been done in other states, the results are there, and the results wouldn't be there if the patient wasn't eating the food. So it's kind of like a chicken and the eggs.
And also, if the mother is giving food to other members of the family, then there's a food insecurity for the whole house, right? And there needs to be a greater intervention, a community health worker, somebody to help navigate that whole family to get the food that they need and to, address that need. So, I definitely need to get that medically tailored meal to the person in the household that has the health condition it's addressing, but you also have to figure out how to address the food needs of the whole family.
Start getting your questions ready. I've got one more for each of you. And let's start with you, Daniela. So we've made a little progress in NMDOH in the last 2 sessions, like this much, but toe in the door, things are moving. What do you see as next steps?
So, session passed.
Tailwinds.
Okay. So when, we have a bill that passed, there's staff at HHS that are working towards implementing this bill and that are receptive to comments from stakeholders. So like, our work isn't done just because the bill is passed. Now it's like, how do we operationalize this bill? What does it look like from rules, if they need to provide rules, if they need to figure out provider types, if they need to figure out eligibility, Medicaid policy. There's so much that goes into having that patient receiving those services and that provider receiving reimbursement for those services too. So there's a lot of work, more work ahead for any group that's been involved on the advocacy to support this bill. I think for NMDOH in general, for federally qualified health centers, this is part of our DNA. We've been doing this work since the inception of the model, and there's a lot of other needs too that we're trying to figure out how are we going to address with continued strained resources. And so we're trying to be creative about like, what are some of those other things that we can tap into, whether it's something like case management for children and pregnant women, and allowing that case management to support some of this other work as well. So those are some of the things that we're tracking, just following this bill in our space.
Yeah, so a little bit more about MAHA. I think when you think about the Make America Healthy Again movement, I think a lot of people that are drawn to that movement, it's coming from a very genuine place. Like, they just want people to be healthier, as do we all. Everyone in this room wants our nation to be healthier. And so, unfortunately, I think what we've seen kind of play out is that they're chasing a few shiny objects while real damage is being done to these foundational programs, to SNAP, to Medicaid. Nutrition education, SNAP Ed was completely cut. And you think to yourself, like, well, how is that making America healthy again? So I think one of the biggest opportunities that we have going into the next session to kind of flip it on its head is say, how can we harness the energy and the good intentions and the momentum that the MAHA movement has, and hopefully steer it in a direction that is more positive and evidence-based, and to really secure some wins. And I think that that's a real area of opportunity for non-medical drivers of health. But we do have a lot of work cut out for us on defense. Like I said, the state is going to be responsible for paying millions of dollars for SNAP potentially, and they're hundreds of millions of dollars, yes. And so there is going to be a microscope on that program like never before. And this narrative about waste, fraud, and abuse is out there. And so we're really going to have to head that off at the pass and do a lot of educating with our legislators about what SNAP is, who is on it, what the regulations currently are, and educate them about the difference between, for example, SNAP fraud, which is less than 1% of the entire program, versus, SNAP theft or a payment error, which are both examples of something that aren't fraud, but usually get lumped under that term.
Kind of building on what Daniela was saying, you're not finished when your bill passes. You have to go implement, right? And we learn a lot through implementation. And so 2 sessions ago, we were able to pass a bill, House Bill 1575, that allows community health workers and doulas to be Medicaid providers within a small program within the Medicaid program called Case Management for Pregnant Women and Children. That program was created before we had health plan, managed care, and service coordination. And it just really, it puts the health plans in a weird position because they need to they can't duplicate service coordination. The intent was really to get community health workers into the mix and the conversation in Medicaid and doulas, and we've done that. We now have a path. So I think what we're looking at leading in next session is how do we build off of 1575 and maybe change that case management for pregnant women and children in a way that makes it work in today's terms. It's an older program when we needed a case management function. It's a state benefit that was created at a time and a place, and it needs to be modernized and changed. Or can we look at expanding community health workers beyond that program? But I think that's kind of the next conversation around non-medical drivers of health next session. We implemented, we learned, there's a lot of issues that we need to fix, and let's go work on that next session to continue to build that program and allow those community health workers and doulas to do the work that they really are successful at. There's that, and then I think the other thing, we kind of have alluded to it a little bit, not on this panel, but previously, and I think there'll be a lot of conversations around it, is the technology piece. If we're able to do in lieu of services around these non-medical drivers of health, if we have community health workers That bill from 2 sessions ago also requires health plans to screen pregnant women for non-medical drivers of health needs. Well, all this work is going on, but if we're not interoperable and the FQHC is doing the work and the service coordinator of the health plan is doing the same work and screening the same woman, and the food bank's also screening that same woman, and we're all screening this poor woman. She's tired of being screened. She's going to stop, answer questions, and we're not going to be identify those needs. And maybe it's appropriate for the FQ to address the need, or maybe they need to refer back to the health plan to address the need, or maybe they need to make a referral to a food bank. Until we have technology that speaks as interoperable, we're never going to be able to really have it. We need the infrastructure to have a solid system to address non-medical drivers of health. And I think the Texas Health and Human Service Commission is going through the sunset process every 10, 12 years, and agencies completely reviewed from up, down, between this, everything. They look at programs, functions, organization, and I think it's the opportunity to discuss technology and the infrastructure leading into the sunset session. And next session is going to be all about health and human services, not just because of OB3, but because of that whole sunset process.
Last remarks before we open it up.
I just want to connect to the Rural Health Transformation Program as well, just because that is something that we're tracking closely. If you look at the state proposal, there's language in there too about addressing chronic disease and how is it that you have partnerships with community organizations for wellness centers, for after-hours clinics, for ongoing chronic disease screenings and education and those types of opportunities. And so that's something else that we'll be tracking with too. I think, at earliest, we'll know by the end of the year, Texas is well positioned to receive some of that money. And so I think that will be another next step, is to figure out how can we work closely with those rural counties that are eligible to receive funding to tap into those resources and come up with collaborative approaches among food banks, FQHCs, other providers, health plans to try to address some of these things in those areas as well.
Quick, I was looking real quick to see how many days we have until the next session, but I think somebody will throw something at me if I say it.
Please don't. Do we have questions from the audience? Well, while y'all are thinking, I'm going to ask another question then. So we've talked today about language. Alvaro talked us through why we have NMDOH and not SDOH. No one's talking DEI anymore. We pretend that health equity isn't a concern, even though we're all still working on that. So how are you approaching your work differently in terms of the language and the communications you do to achieve the same kinds of outcomes with legislators that you were trying to achieve before we had this new way of speaking about everything?
We meet and try and frame our bills as can we talk about outcomes, and can we talk about cost savings? Can we approach this from a cost savings or a cost containment initiative? Because that always works, using their language. So yeah, I mean, when we were talking about in lieu of services, trying to tie that into the Make Texas Healthy Again conversation. So you kind of find what is it that the agency or the legislature, the policymakers are really honed in on at that time, because it changes. And we're going to have a huge new freshman group. I mean, people are dropping like flies. Every day there's a new announcement about somebody not rerunning. So it's going to be a lot of education. So no telling what the shiny object will be next session, so framing it within that. But the clients and everyone I work with, before session, we all did very deep dives into all of our websites and our materials to make sure they didn't have any words that would trigger in a negative response if we're going to go try and move things forward. You have to kind of work with what you got, and we know what we stand for and we know what we want to accomplish, and sometimes you have to use different words or different ways to get there.
Yeah, to Lori's point, we would focus a lot on cost savings, but also too with FQHCs, sometimes we would talk about our impact in the community with the patients, or we would flip it to our impact in the community in terms of jobs that we would provide. And so flipping the script as economic drivers as opposed to just serving the underserved or those with Medicaid or Medicare. And I think that was also, to a lot of those that were also small business owners, they were like, oh, it's hard. The lines are really, really tough in order to just pay for things, the cost to pay for supplies, for materials. They could really resonate to that. And so while we wouldn't necessarily hide the patients that we would be serving, we might focus on populations of interest, whether it's pregnant women or older Texans too, that we want to make sure that we're addressing just in our day-to-day conversations.
Yeah, ditto. I mean, focusing on, program integrity and like streamlining access, any sort of kind of technology improvements, right? Things that can save costs. And then, I think appealing to neutral language that resonates with folks, like affordability, right? We hear over and over again the cost of food, right? The cost of food is so high right now, and people are having trouble affording it. And that cuts across party lines in a way that, if I just start talking about SNAP from the get-go, people are going to shut down. But if we can just start from a baseline of agreement that, like, hey, food costs are high, people are struggling, hopefully we can then, start to make progress on what are the real solutions to addressing that.
Audience questions? Back here.
Hi, everybody. Just acknowledging the amount of the investment that's needed for clinics like FQHCs and healthcare to work on NMDOH programs, and the contraction that's coming or potentially coming with ACA. Are there other, on a policy side, are there conversations that are occurring that involve non-governmental ways of, non-governmental models for access? Example from before was like a 3-share, but there are other conversations that you're hearing from the elected officials who are interested in other models, just to fill in the gap. Obviously, it's not optimal. Government ones are the best, but just kind of curious about that.
Yeah, I think we talked a little bit about it, Tan, where direct primary care, right, has been a conversation piece of the Capitol. I think, you guys have.
Yeah, so not this session, but last session, we were able to pass a bill for primary care access so that uninsured working adults and small businesses could have access to a program where they can pay into, let's just say, it would be set by each FQHC, maybe $100 per month, maybe $60 per month, and that would cover a set amount of primary and preventive care services. And so it was well received at the legislature. It passed, it just didn't get funded for whatever reason. And so I think that there is a door opening to other arrangements out there, especially if you bring in small business owners, working adults, those types of populations to address that. I think right now with other conversations happening around the subsidies going on with the marketplace right now, that's just something that we'll have to maybe get creative next legislative session, is what can we come up with to just continue to, one, promote the importance of this and say that it's an investment both for the individual, for the business owner, for the state, but also it can have a really good long-term impact if it's done right. And I think that's one of the challenges with our models, is that you might help that child, that pregnant woman, but you're not going to see the return next year. It's going to be at best 5 years, 10 years, and so it makes it really hard for modeling on our end, but it doesn't mean that we don't try to propose pilots to try to move forward with that. So we tried this session again. We didn't quite get funding, but I think we have a couple of things in our sleeve to try to be creative again for next session.
So a bill passed, but it didn't get funded. Explain what that means, how that happens, because it seems like a bill passes, we hit what we want.
It's not over till it's really over. And so, yes, we had hearings in the House. We had Representative Frank. We had Senator LaMantia. They were working together. They're saying, this is a great bill. Let's move forward with it. It goes through. It gets signed. And then we're looking at the appropriations bill, where we're looking at line items and looking to see if there was funding or not, and we see that there isn't a line item. And they said it was an oopsie, it was a mistake, it should have been in there. And so at the end of the day, you can't go back and add $10 million for this thing. We tried through a budget writer list last session, but there are so many other priorities that it didn't quite make it. And so yes, it is possible, even if you have agreement in both chambers from the governor for your items to still not get funded and still not be operational.
They've also started. They've also recently started putting in bills, kind of almost a disclaimer, but there's a section on a lot of the bills, especially Medicaid, or those that could potentially have a cost, that says the agency does not have to implement if not funded. So it's a new kind of provision that's put in a lot of legislation. So I'm trying to think, there's been a couple like that have been really good bills, but they didn't fund it. So the agency was like, I think there was, I'm trying to think of the big one. There was a big one recently, but yeah, where the agency, if they don't have the funds to do it, they can't implement it. So it's another good way to secretly kill a bill, because the budget is the hard thing about the budget is a lot of it's done behind closed doors and it's secret. You don't always know what's going on and being discussed. And so it's where you want to get your stuff in, but you don't always know if it's going to get in. And then if it doesn't get funded, then your bill's dead too.
Audience, somebody way back there? Oh, okay, here and then back there.
Thank you. I have two questions. One is, if it passes and doesn't get funded this time, because it exists now, will it get funded next time? And my next question is if it doesn't get funded, can you look outside the legislature for money? So could you go privately? Thank you.
Yes, and so we tried last session to get it funded via a budget rider, which says now that this is now in statute, please add money to this so that we can implement it. That didn't get passed. We tried. But we could always have the option, and this is the way it happens too with NMDOH initiatives, where we go out to try to apply for grants or try to do other partnerships in the community to try to get this going. We're aware of one FQHC that is partnering with a roofing company. And so they're able to provide some primary and preventive care services where their roofers pay one portion of it and the company pays another portion of it. So it's possible, but it's harder to scale up.
My question is probably going to be pretty fundamental, and it's about, I hear y'all when you're talking about speaking with elected officials about what's happening and the importance of passing this legislation. I'm going to flip the script and ask you, how are you educating your constituencies about the fact that the legislature needs to invest $800 million minimum to implement your STAP education and administration, now that it's going to be on the state's side? How are you educating your FQHC patients and your workers about the real issues with regard to the federal administration looking at different designations now of what you are and what you qualify and what you can spend on undocumented as well as uninsured patients going forward? And then I'm thinking about CHWs. They save a lot of money in this state, but we have to think about how we're talking to our own constituencies about how they're reaching out to their elected officials. So I'd like to ask y'all, how are you educating your own constituencies about the incredible need? We have a 2026 midterm coming up, and these elected officials are only there if they're elected. And so my question to you is, how are you getting them informed and educated about these issues so that they have a little bit more power and agency in their own way of serving their clients?
So I'll start. So each FQHC is required to have a board made out of community members. And more than half of that board has to be patients. And so that is our starting point when we have new policy initiatives, is to go to those boards and to just talk to them about what's down the pipeline. So then they're able to make decisions, whether it's on their sliding fee scales or on their policies or their expansion plans, to plan ahead for what's coming up next. And so we mobilize the board, we keep them updated, and then also being a member organization, we have a lot of visits. We have our advocacy days at the state capitol, but we also organize fly-ins at the federal level to make sure that they're going and visiting. And then in the interim, we try to invite elected officials and also those that are candidates to come visit FQHCs to learn more about what they are and how the choices, the decisions that they help make impact their communities as well. So it's not just a one and done deal. Throughout the session, throughout the year, there's different touch points that we have with elected officials to get them engaged, as well to engage our board members and our patients in that. And a lot of them are so busy with their day-to-day of just like, how do I just keep my doors open? How do I make sure I have enough staff available to serve my patients? And so at TAC, we take that as a big responsibility, that if we can make their job a little bit easier, and we track this, complicated, wonky policy stuff, and we give them a high-level talking points, we try our best to do that, because at the end of the day, they're the voices that the elected officials are going to listen to.
Yeah, and OB3 contained a lot of SNAP changes, not just the cost shift to states. There are changes to who's subject to the work requirements, who's even eligible for the program, restrictions on immigrant eligibility, and others. So what we try to do is distill the wonky policy information into helpful one-pagers, talking points, social media graphics. Sometimes we host webinars to educate the community on these changes, what is coming down from the federal level, what to expect. Are they still going to be able to receive benefits, and if they are newly subject to the work requirements, how to comply with those. So I chair something called the Texas Food Policy Roundtable, and it's a coalition of over 80 organizations in the state. We have food retailers, we have agriculture, we have healthcare, education, city government, you name it. Are part of this coalition, and so we push a lot of information out through the coalition to, so it's reaching, those member organizations, but also all of their networks and community members, and so we try to do that. And our food banks also engage regularly with neighbors that they serve, whether it's through direct food distribution or SNAP application assistance. And we are collecting stories about the impact of these changes, and that we can then lift back up to our federal delegation. I know the Houston Food Bank has a neighbor advisory council and trains neighbors to become advocates, to come to the Capitol with us and advocate alongside us. So it's a multifaceted approach to how we make sure our community is informed and engaged.
And with the Episcopal Health Foundation, we recently teamed up with Community Health Choice to do some member interviews and stakeholder groups where we talk to individuals that are currently getting marketplace insurance. And it is a fine line, Rosie. You don't want to scare people, but they need to know it's coming. But it was really eye-opening that the majority of people we talked to knew that, coming up is going to be a hard decision for them what they're going to do about healthcare. They were pretty educated and aware of what was happening. And so, really, putting together our scripts and our conversations in a way that puts it in layman's terms so people understand it, but also we learned a lot from these individuals. And we've done that as well through the Episcopal Health Foundation with a couple of the other Medicaid health plans with pregnant women, to hear about their experience and, what are their challenges. And one thing that I found most interesting about that member engagement and those conversations was majority of those women we talked to, their network and who they go to for information are their peers and their friends. Not necessarily the doctor, not their health plan, not their service coordinator, and not a website or not a pamphlet, but talking together in peers. So we're finding the peer-to-peer group conversations are very informative, and especially when you have community health workers or individuals in the room that know how to tease out that information, have that conversation. But there's a lot of people paying attention to what's going on, and it is great to hear how much people are watching. It's just, trying, then the work you all do to try and get them engaged is the next step.
All right, I think we're about to break for lunch. Charles may want to come up and say something. I want to thank all three of you for being here today, but really for the work you do day in and day out, because these bills don't just come about, and it's because of your work that we make the progress we do make. So I thank you for that. And Charles, am I supposed to say anything or just say go eat lunch? Lunch is back there. Oh.
So you've all been listening this morning to experts, and we recognize each of you brings your own expertise, and we really want to learn from that after lunch today. So when we return from lunch, we're going to go out to the lobby, pick up a box lunch, bring it back in here to eat. But after 12:45, we're going to have small group discussions. There's a sheet on your table that has a purple banner that kind of walks you through a couple prompt questions to talk about priorities and opportunities that you identify, and then we're going to have a report out to the room from each of the tables just to kind of gather some information from each of you. So we'll have about a half hour eating time before we get into the small group discussion. So food's just right out through the doors. All right, I've been hearing some interesting discussions. We're solving a lot of problems of the world here. We want to give a chance for everybody to kind of report out to the room, like what their table surfaced as priorities or important topics. So I'm just going to kind of popcorn around the room and take the mic around and have people kind of report out what they heard from their table. I'm going to start right up front here.
Okay, absolutely. So we had a fascinating discussion. I'm here with a great group of students from Channelview about the recent policy around the banning of cell phones at school, right? So we want to know about that, right? So it seems like, and I think this is true of a lot of policy, that it's very hard to implement a policy for one group of people that doesn't affect other groups of people. So I think there was a question of fairness when it comes to policy. So in that respect, it seems like we had a lot of agreement that it all comes back down to just basic fairness, and just because it doesn't affect you personally, that you shouldn't care about the person next to you. So had a great group. Thank you, guys.
Great discussion. Carol, I'm going to come to you next.
Thank you. Hi, everyone. So we had a great conversation here. We have a mix of academic, nonprofit, county government, and state government. And so our discussion really focused on, the impacts that, we're losing infrastructure that we've spent so many years building. And Lori's comment during her last panel was really instructive to us about just passing the legislative bills is only step one. There's so many things you have to do. Make sure there's money, make sure it's being implemented, make sure it's being evaluated, and that resonated a lot with us. As we also talked about the importance of the terminology and how that changes over time, and we have to flex with that. So we discussed how we needed, again, creative solutions. We have to be strategic about how we solve these issues. Nonprofits, foundations can't fill the gap completely, and we know they're being called upon in increasing ways. We see lots of opportunity with AI and tech. How do we leverage that to accomplish some of these goals? And when we looked at number 5 about actionable next steps, it really is, what is the next right thing, right? How do you make sure that the accomplishment you had doesn't get lost? So can we do things like the MCO framework that recently changed? How do we leverage that? What do we learn from that in terms of how the MCOs are partnering with the rural providers, or how the lessons learned that health plans discover are shared with other health plans and other stakeholders? Oh, okay. And then similarly, there's great technology, but how do we make it easier, right? You can't just say, okay, here's a tool, but it doesn't always work consistently every time, and people get frustrated. We have to make it seamless and easy, and we have to also work on a better communication strategy, recognizing there are multiple audiences we need to speak to, and how do we engage them in developing that technology, that language, that communication strategy, and knowing that there's going to be more than just one.
Thank you, Carol. I'm going to come to you, Denise.
Trying to make sense of my chicken scratch here. We talked a lot about things that resonated with this table were around, translating into implementation of bills. And, just thinking about it, there has been examples of other states who've kind of taken these baby steps, and then how do we build upon those and go in that way even from other red states. We talked a lot about the rural health bill, that there is a very pro-Texas federal government and funding coming this way, and how do we really strategize around that? That was a big part of our conversation. Language matters and understanding that audience. We talked about the elephant in the room being that there is no incentive alignment, that good evidence doesn't always equal those legislative outcomes that we're looking for. So how do we reframe in a way that makes sense to both our constituents as well as the folks that we're trying to educate and advocate? We talked about, again, so just kind of taking opportunities, leverage opportunity to work where we are today, understanding that not all of the pieces are where we want them to be, but how do we use the opportunity to create scaffolding so that ideally when there's a new dawn, like all of those pieces are there, we can continue to build upon those and implement. One thing from a gap perspective, and I don't have a policy solution for it, is like the elephant in the room. There's no real solid plan to address rising healthcare costs. In terms of gaps as well, no understanding of the totality of needs and resources available because systems don't talk to each other, especially as it pertains to social care. And then so for number 5, which is actionable next steps, we had some folks really like Lori's suggestion about improving the CPW program, like using that existing infrastructure and building upon that as something that's already in place so that CHWs can get reimbursed and that workforce and that work can be sustained. Again, capitalizing on that pro-Texas federal government focus. We talked about standardization of risk assessment for patients, and then just in general improving coordination of care.
Denise. Josh, I'm going to come to you next. Thank you. Okay, so our table was very policy focused. So for question 1, one of the themes we really liked was the discussion around House Bill 26 implementation support. We also talked a lot about civic engagement and how it's really important to navigate legislators down the pathway they need to go down with the right education against all of their competing priorities or it being a part-time job. I think that's really a critical one. And how do we put the knowledge in the hands of the community members that have that opportunity to engage with legislators? For question 2, we talked a lot about tech and AI enablement and how, what's happening around that data and the perception of it being just another vendor bill, even if it's something that's truly needed. And so there were also some shared concerns about how, AI, of course, can be used for vulnerable populations, but how can it be used against those vulnerable populations? And then we also talked about how, we seem to be good at closing the loop in our respective areas, but how do we really pull that together statewide and kind of what Denise said about building that scaffolding and that infrastructure that we need to support it. And then for the last question, so the last question we really focused on CHWs and how through every conversation that we listened to this morning, there was this assumed reliance on community health workers as that infrastructure. But in order to do that, especially in some of those rural areas, we really need to focus support around those training centers or increasing the scope of CHWs incrementally, like through the CPW program, so that we can really enable things like rural transformation support, because in those areas there tend to not be a lot of CHWs, and how do we really augment those areas, especially with all of that funding coming in around rural health transformation.
Thank you. Thank you.
Okay, good afternoon. Our table is made up mostly of nonprofit and health providing agencies. We had a great conversation. Policy themes that felt the most timely and relevant was the focus on kind of quality and cost effectiveness that a lot of the organizations are doing, as well as, unfortunately, shifting the language. I'm not a big fan of that, but how you talk about things so it can resonate with legislators. Also talked about the importance of the shift from paying for health instead of paying for medical services and how important that is, and recognizing, even as Alvaro said was talking about how it was kind of difficult to make that connection with asthma. We had someone here from Legal Medical Partnership who was saying the same thing happens, but legal services have an impact on your health. So we, really talking about how we can pay for health instead of just medical services is important. Disconnected, things that kind of felt disconnected or kind of like, is the continual requests from legislators for data and evidence when it's like right there in front of them. It's like, we have it here, and the failure to pay attention to that. Another one that was a little disconcerting was about how we pay the most, this country pays the most for on medical services, and we have the worst health outcomes out of similar countries. And so a policy change that could potentially close that gap is if you conduct some type of research or in-depth research looking at countries across the board, and it's not just about what they pay in their medical costs, but also what do they put into their social services or non-medical services, I guess we say, and how that lines up and what impact does that have on their outcomes? Because it's not just, oh, they pay less in medical, we pay more, but is it something else that they're doing, right? Or are they investing in other areas that's making that their health outcomes better? And also maybe looking at that across states. So we had a conversation about someone who came from another state to Texas and lost a really important Medicaid benefit that is causing stress and potential health issues and a loss of income by coming to Texas. So kind of looking at that and putting that research out there. Most actionable next steps was building on the Food as Medicine program, that pilot project, being able to expand that to children and then to other populations, as well as looking at increasing reimbursement for some of the expanded workforce, the supportive healthcare positions like peer support, doulas, lactation consultants, those that have been approved, but being able to expand reimbursement for them so people are still able to access the services, because we know if they're not being reimbursed at a reasonable rate, then they'll stop providing that service. So those are some actionable steps.
Thank you.
Good afternoon. I had a wonderful group of about half high school students joining us today, and then half professionals from nonprofits who also had a lot of experience of volunteering and kind of working directly with the community. For our table, they're kind of reflecting back on the conversation this morning. Some of the topics felt very, very relevant, and then other kind of some of the conversations and themes felt kind of disconnected to what our table was kind of seeing in their day-to-day life. So for example, if we're talking about data interoperability, where their challenge is, the food box arrived and all the food is spoiled. Or for example, one of our table mates shared that Meals on Wheels in Montgomery County, for the first time in their entire history, they are reducing services to seniors this fall. So kind of just reduction in services. So that was kind of one of the themes. We also talked about how a lot of the policy, particularly this year, but a lot of the things going on in the policy realm, it's kind of a distraction. So kind of all these nonprofits doing good work, instead of having to spend their time doing the good work, or having to spend a lot of time kind of reacting to what's going on in the policy world. We also had a really interesting tangent talking about the recent election and the propositions, and how we should be advocating that they are written in neutral and lay language, how that would be really helpful so people know what they're voting on. And then finally, in terms of most actionable step, really the theme from our group was just really needing to do a better job of listening to the people.
Thank you.
Hi everyone, so I'm Robin. We had a small but mighty group here of education focus, and I think I was only rep for healthcare, but we talked a lot about the different policy themes and how it aligned with our work, and what came up was the focus on Medicaid and Food as Medicine, supporting those initiatives, as well as the recent CPW initiatives to support community health workers with case management and care navigations, as well as rural healthcare needs, and identifying funding, supporting that funding with also creating a workforce to support the rural community, and also the direct relation between education and healthcare. How can we draw those lines between identifying and educating the community on specific healthcare needs as they deal with preventing chronic diseases like preventative care. And also, the second item here is the disconnect and how could policy changes close that gap. And so one thing that came up, and I think I can attest to this in my work, is we do really well with receiving funding to implement things, but how can we make them sustainable is really critical. Or I know a lot of showstoppers and movers and shakers are in this room that can do really well with 2-year, 5-year grants, but what happens at year 3 or year 6? How can we keep that sustainable is really important. And then challenges for non-medical drivers of health. One thing that came up at our table is like, how can we maybe minimize those non-medical drivers of health and maybe focus on 1 to 2 things, because we know at times it can be very broad. In clinics, we may be screening, and there may be some screening fatigue for patients that, we're screening across the board, right? How can we hone that down and focus on what the real risk or cause are, those gaps in care, and meet the patient where they are, the community where they are, and then identify the connection between teachers and healthcare systems. How can we, utilize at the school level? We know our teachers are sponges and absorbing a lot. How can we communicate that from school to, the clinic, to identify like what are some causes that are going on in the home that we may not be seeing on those screeners when we're in the clinic. And then also experiences or stories to strengthen our case. The overarching highlight was patient success stories. I think, sharing the story behind the data, behind the bar graphs, behind the, beautiful data in charts that we see, like what's the real story, so that we can get to the bottom of the cause. And then integration, I believe, was how can we have some actionable steps to strengthen integration in healthcare. And this is where a lot of ideas came up. Reducing screening fatigue was at the top of the list, as well as increasing data sharing, addressing the disconnect, and building those pathways to share information. We have a lot of great organizations within our large city of Houston and surrounding areas, but how can we more effectively and efficiently share resources, share communication across the board without the bureaucracy or the red tape or the little things, and how can we best facilitate and share that info? And last but not least is utilizing AI to make our processes more efficient.
So we went a little bit off tangent, but we were talking about how one of his passions is coaching youth soccer. And so figuring out, like, is there a creative way to take health center patients that are children, potentially Medicaid beneficiaries, and work with health plans or other community partners to help sponsor a wellness program to support physical activity through a youth soccer team or something like that. So we were just kind of brainstorming what can be some of those public-private partnerships that go beyond, on top of non-medical drivers of health, but thinking about broader, just like being outside and wellness, getting fresh air, and just trying to be creative and not just thinking about like, I'm here for a health visit, but more of like, I'm here because I want to play soccer, and that's also going to keep me healthy.
Thank you.
Hi, everyone. I was here with kind of a split table. We are representatives from HHSC, actually working on implementing House Bill 26 from the Quality Division, and we were joined by some representatives from Houston Food Bank. So we started off with a lot of interesting conversation about how to address food insecurity, how to address nutrition needs in the healthcare setting, and sort of integrating those food systems and those strategies for addressing those needs within like a clinical setting, within like a Medicaid capacity. But we also spent a lot of time focusing on funding. That is very important for all of our work. Funding is how programs become sustainable, and it's often sort of missing from the conversation, and the incentives for instance, like in the legislature, there's maybe some misaligned incentives with funding, because it can be very helpful for there to be a fiscal note that shows that there is no cost to implement. But for the people who are implementing it, for the agency, for the organizations who need to provide these services, those funds that may not have been considered and could have been seen as a positive, they could be really detrimental and really slow down the how productive that those bills can actually be. So that was the focus of our conversation, and also considering specifically, a fiscal note is the cost to implement a bill, but it may not consider the impacts more than 2 years down the line. It may not consider the cost savings that occur more than 2 years down the line. So really taking a broader scope of how funding is important for a bill to actually be implemented to its best potential, and maybe considering that more in the policymaking process.
Thank you.
Thank you. Well, we also had a diverse group here at our table. We had folks that work in the food bank space, in family planning, in mental health, and in managed care and community referral types of roles. So it was a good cross-section. And we really felt that a lot of the themes of today aligned with the work. There wasn't really anything that didn't resonate, but to at least someone in the group. We had an interesting conversation about some kind of tactical collaborations between like medical providers and food banks, for example, and like how the cross referrals and collaboration can happen, and even like tactics on communication campaigns and things like that. And then we had a good conversation on, I guess, big picture, how we can have more of an effort to work together on policy or on these systemic inequities. And right now we have there's people that are working on housing policy, health, food insecurity, transportation, but really it's all connected. And so from a civic engagement and advocacy point of view, how can we be more collaborative and look at the whole root cause there? And we did, I think someone else mentioned this, but there was we were expressing frustration about the fact that we have research for a lot of these and, solutions, but our, policymakers aren't necessarily using that research. So how can we get more community involvement, more voices at the table to kind of demand that and be more research-based and actionable, I guess. And then we had a good conversation about how, if we had all the money in the world, what would we do to solve it? And we really, a lot of the folks at the table thought it came down to education, and that was kind of the core root for a lot of the questions and the issues that we see. And then we did talk quite a bit, which someone else mentioned too, about the community health worker program, and that could be, something that could be beefed up and invested more in Texas and more intentional, that could help a lot of folks. And then finally, the idea that people are being screened at so many different points within the system. And so how can we streamline that, be more intentional about what information is being collected, where that information is going, how it's being used, and how we can eliminate gaps where people are kind of falling off in the referral process. So thank you, guys.
So my group was comprised of health plan, community health centers, federally qualified community health centers, social service with Ripley, and a Rice undergrad student. And we started to ask on the first question about policy themes, started to talk about, food. Food obviously was a major focus of this, the conversations across the entire morning, and the alignment there, but also, because it's tangible, we all can understand it. It's not a hard concept to understand it and think about taking action on. But what we started to drill down a little bit more about that was the connectivity. I understand that there's food access issues for my clients that I serve, be it through a Medicaid STAR plan, or at your federally qualified health center, or at your social service agency, but there's the connective tissue there is we're missing some critical pieces to start bringing it all together as a whole group of constituents here. So what is the next step? And we began to talk about, like, I have information to data, you have information on data, but our data can't talk to each other. Or if it does, it takes us a lot of time and money and energy to figure out how we can use that data together. So we started thinking about interoperability. But our undergrad student here started talking about interoperability because she was working with Urban Harvest and wanting to make sure that their systems are talking. I said, let's stop there and make sure that we are all understanding what we mean by interoperability. We all assume that we're all on the same page on that. And I said, if I was an elected official, what would you say to me to say we need to work on interoperability? And so we started talking about, as a community here, is there a way that we can start landing on a policy that connects all of us, and that is data. Data drives everything, and we're talking about food access, or we're talking about other social services, et cetera. That helps your area and your constituency, but collectively, we can all agree that we need data. And we need to be able to use it well and be able to move either our own policies, move our own ways of giving care to our constituencies in a better way, et cetera. So then we started to drill down a little bit more about, well, what does that look like from this group of individuals and this group of experts here? And what we landed on was some type of, is there a way that we as a coalition can start talking to elected officials about interoperability so that it resonates with them, like the MAHA movement? They started talking about it. We heard it. We have data on that. There's data we get that the data's there, but somehow we keep missing what that looks like from an elected official standpoint. So is there an opportunity for us here to think about landing on a policy on data? And what does that look like? If we're saying we need interoperability, there are how many HIEs? 10, at least? 5 formal, yeah, and at least 10 that are kind of tangible. But none of them can talk to each other unless there's some type of aggregator, a way to do it. So is there a way, since the state has invested in funding, direct payment program money, an atlas of saying, hey, you managed care organizations need to have attestations from hospitals that say that they report to an HIE so we can draw down this funding, that we, as a constituent, can say, we get you. You clearly think about this. You have an all-payer claims database, state, that you created. You just passed a bill called HICAP, Health Insurance Coverage and Cost Assessment Program. So you're looking at how you mandate benefits and making sure on the commercial side and on the public side how this is really working for our constituencies in Texas. How can we think about ways that we can move the data conversation so that we can use the data to demonstrate to them in the way that they are seeing is actionable? And that's kind of where we landed.
Rosie.
Hi there. Our table had a mix of students, researchers, and concerned citizens. And we spoke a little bit also about interoperability. We also spoke about how there is momentum right now on food as medicine and nutrition. So how can we capitalize on the momentum that exists when it comes to non-medical drivers of health? We also spoke a lot about coalition building and working together, breaking down silos. And then we also discussed what makes people trust, what makes someone trust someone else. Because a lot of this work requires community trust and it requires you to trust doctors or community health workers. And so we spoke about how we trust people with familiar backgrounds, people who are non-judgmental, people who have approachability. And that was our conversation.
Thank you, Joe.
Well, my table just had to leave, but it was composed of all the high school students from Channelview High School, which was great. It was a great conversation. So when we talked about what resonated with the group of young people, the North Carolina conversation about what's going on there and how they're addressing gaps in care for kids was really important to them. And, you know, it was super interesting that it's happening in a place that has a very similar political environment to what's happening in Texas. The other thing that really stood out was the legislative process. So they learned a lot about how that actually works through the panel conversation. And it really stood out the length of the process, how long it might take for a bill to actually pass, how many sessions it might take, you know, how easily a bill can fall apart over time. You know, if it doesn't get passed once, is that a priority the next time? You know, what happens to that? And then also the fact that a bill can pass and not be funded was a big surprise to the group here. And so that was pretty scary stuff, and they were talking a lot about the budgeting and how that all works. And then we just had a quick conversation about gaps, what they saw as gaps, and really the conversation was focused on gaps in this conversation where they had certain issues that were of interest to them that maybe weren't covered here. And one of those was immigration policies and the impact on health. In that instance, reproductive health care, and then one that really popped was mental health issues. So increasing depression in youth due to, you know, social media, environmental factors, and stress factors, and all these things contributing to that. So that keeps going up. And, you know, how are people addressing those things in youth? And so that really popped in the conversation.
Thank you, Brett.
So at our table, we had some nice representation, interdisciplinary representation from public health, education, research, clinical practice, and consulting. And a couple of the themes that kept popping up were having more interdisciplinary representation and collaboration when we're talking about this stuff, and the disconnection, like you said, breaking down silos, having a disconnection between practice, policy, research, and community members. And, you know, sometimes the left hand doesn't know what the right hand's doing. People aren't talking, systems aren't communicating. And so, you know, as a community provider, I may not know what's happening at the Capitol, and I need to know what's happening at the Capitol, and I need to know how to go and advocate and testify, et cetera. So just breaking down those silos, because I think having that, breaking down those silos and building more of that capital and that power is really what's going to create more change.
Thank you.
Thank you. So our table consisted of CBOs, MCOs, managed care organizations, community-based organizations. I know we should know that, but I'm not assuming. This morning reminded me not to assume. A lot of times when we're in our roles, we assume everybody in the room knows what we're talking about. So that brings me to, and we also have local health districts represented here, so that brings me to our main topic of discussion is healthcare, or excuse me, health literacy, and how important it is for folks to be informed before you can even have a discussion. I found that in working with policies, be it in some other roles I've had, Affordable Care Act, which has resurfaced, or just talking about basic policy information, health information access, you first need to make sure the person has the information available to make the best policy decision. So that was the theme at our table today, and I think what brought it home was earlier today when the question was asked of the panel with regards to what are you doing to inform your constituents. I think as policymakers or those of us who work in policy, it is our responsibility as an organization to have a level of healthcare literacy before we go out. And we have these meetings, and we have these discussions, and we serve on work groups that we be informed. And then we turn around and we share with others so they too can navigate through the process to make great policy. Thank you.
Thank you. Well, there's a lot of wisdom in this room. I really appreciate everybody taking the time to work through these questions and report out. If you didn't see on the screen here, our friends at Working Partner, Jessica Pugil and Brett Sinclair, designed this exercise for us, and she's been recording up on the screen kind of a summary of our comments, and we'll send this out to the group after the meeting. I appreciate y'all sticking with us till the end. For some of us, this is our daily topic of work, and others of us work on this more intermittently, but I think there's real value in coming together in one room and kind of sharing the same ideas and visions about, you know, where we're at, where we're going, and what's possible. Even though for many of us this work is our profession, it's also personal, because the quality of your life ultimately is going to be impacted and determined by the level of health that you can achieve and how long you can hang on to that health. It's also impacted by the health of the other people in your household and the people in your community as well. So if Texas wants to realize its vision of being the best state, we've got to have the best health out there. And I think addressing non-medical needs within the healthcare delivery system is a way we can turn that cost curve and achieve outcomes that really matter for Texans. And with that, I appreciate you all showing up, coming out, and be on the lookout for a follow-up email on this. Bye.